I think it is well known that with the establishment of Chapter 224 and the creation of the Health Policy Commission, one of the important responsibilities of the commission is to do a detailed analysis of any proposed merger and acquisition that would have a substantial impact, potential substantial impact on spending healthcare dollars in the state, impact on the quality of care of patients in the state, or on access to care. And I think it's also well known that the commission over its history has had a number of occasions where we conducted what's called the CMIR, a cost and market analysis of the proposed transaction. I want to make it clear that what we're talking about today is a draft proposal. The plan is that after the presentation and after the comments that we received from outside members, but before the comments that we received, before the comments that we received from outside, the commission will vote on whether to approve the draft report. Then we will get the comments. There'll then be a 30-day period that which will allow detailed comments to be received from various sources, from parties involved, from outside forces, the public in general, and from fellow commissioners if you so choose. We would then be presented with a final report, which we would then take second vote on. Assuming that we reach an agreement and we have a final report, our responsibilities are then to submit that final report, A, to the general public, B, to all the relevant state agencies that have a potential involvement in this, which would include the state, since it has responsibility to determine determination of need in terms of that, to the Attorney General of the state of Massachusetts, that has a variety of responsibilities, not only with respect to potential antitrust, but also with respect to assure that access, that our philanthropic funding in the state appropriately used, and potentially to the federal government, in this case the Federal Trade Commission, or could be the Justice Department, that also has responsibility with respect to antitrust. So we are in this first stage now of getting a sense of this draft report. And again, we will hear the comments from our staff, from David and the staff. So this is what I'm proposing, is that when you hear the comments, if there is a technical question that you don't understand, feel free to, without screaming and yelling, but in an appropriate way, ask that question right away, because the tendency is once, technical questions, if you wait too long, you forget what they are. More general comments, if you wouldn't mind holding back until the reports are completed. Rather than my sort of trying to make sure that I get everyone in the appropriate time, I am going to give an opportunity to each of you, starting, I warned Wendy, she goes first, to make comments. By the way, I'm not suggesting you have to make comments, but I'm giving each of you an opportunity. And by the way, that's not the only time. If something else comes up later that you want to talk about, feel free. So each of you will be, I'll ask each of you to either make some comments or questions or whatever you more can. Assuming that's okay, I am now going to turn the program over to David.
Excuse me, Mr. Chairman, before you do, I actually need to ask you to clarify something.
Sure.
In your opening comments, you said that our vote is to approve the report. But that's actually not what the motion is. The motion would be to authorize the release of the report. And that is more than a technical.
Well, that's what that's.
I'm
I'm glad you mentioned that. I appreciate
it
that.
would be to move it to the next stage, not necessarily.
Yes, we are not, well, that's right, we are not approving we are authorizing the moving of the report to the next stage.
Okay, thank you. I get confused every once in a while, so I need to be, reminded. Thank you.
Okay. All right, with that said.
All right, great. Thank you, Chair Altman and Commissioners. And this is certainly an important conversation. I skipped, there was our standard notice of material change. I just moved right past that, and we'll start on slide 48. I'm going to turn it over to the leadership team here at the Health Policy Commission, who's been conducting this review in coordination with our expert consultants and economists and actuaries, as well as with all of the input of commissioners. I do want to just say at the outset a note of gratitude and thanks to the parties that are of this transaction. They have been incredibly professional and cooperative through every stage of this review. We understand that going through these reviews does require a fair amount of administrative work on providing documentation, and I just want to commend the parties to the transaction for the spirit of cooperation and the seriousness with which they have understood this review to be part of the shared goals for the Commonwealth. And so I want to really thank them, their teams, and everyone who works there for all of the work they put in to working with us to provide the information that becomes the basis for our analysis and examination. Similarly, we also want to thank and acknowledge the fact that we do talk to other market participants, other providers and health plans, and they too have been incredibly generous in providing information that will inform this objective report. I'm going to turn it over to the team here, but just to introduce everyone here to the team. Kate, to my left is Kate Mills, the Director of Market Performance, Megan Wolf, who's the Deputy Director of Market Performance, and Sasha Hayes-Rosnov, Senior Manager on Market Performance, who has led this work. And so they will walk through these slides, and some of these slides, especially at the beginning, Commissioners, you have seen before in terms of what is the CMIR and who are the parties to this transaction, but recognizing that there are others in the room and who are viewing online that may be coming to this transaction for the first time, do want to just level set in terms of who the parties are and what they're proposing with this new merger. So with that, I'm going to turn it over to Kate.
Great, thank you, David, and thank you, Commissioners. So as you know, our reviews are the result of many months of rigorous evidence-based analytic work, which, as others have noted, relies not only on extensive data and documents from the parties, but also from other market participants, other providers, and payers in particular. We work very closely not only with our commissioners, who are experts in their own right, but also a large team of contracted expert consultants, economists, actuaries, accountants, care delivery experts, and healthcare quality experts, many of whom we are fortunate enough to have them join us today. We issue a preliminary report, and as discussed, that is the goal of today's meeting. The parties and others then have 30 days to respond to that preliminary report, and then the Commission can issue a final report thereafter. We have the ability to refer our reports to the Attorney General's office or other state agencies. Consistent with our approach in past preliminary reports, we do not include any referrals in today's report as the preliminary report, so I do just want to be clear about that. The parties can't close the transaction during the pendency of our review, not until 30 days after the issuance of the final report. Any questions about that quick overview of process before we dive right into the findings of the report? Great. So these next few slides will look familiar for folks who remember our Commission meetings in December and January. This is just a reminder that there are two key components of the transaction that we have before us. The first component is a corporate affiliation between the parties that you see listed here. So that is the Beth Israel Deaconess Medical Center system, including its 4 hospitals, the Leahy system, including Leahy Hospital and Medical Center, the Northeast Hospitals, Beverly, Addison, Gilbert, and Bay Ridge, and Winchester Hospital, and 3 currently corporately independent hospital systems, Anna Jakes, New England Baptist, and Mount Auburn Hospital. Several of these entities already have pre-existing relationships. Both New England Baptist and Anna Jakes contract with payers through the Beth Israel Deaconess Care Organization, or BIDCO, and BIDMIC, New England Baptist, and Mount Auburn are all members of Care Group, which jointly borrows funds and purchases services for those entities, but does not contract with payers or provide centralized operations. And I'll note, we don't have all of the subsidiary groups, all of the physician organizations on this chart, obviously, for the sake of simplicity. The second major component of the transaction has to do with the contracting relationships that would result. Beth Israel Leahy Health, which is what they proposed to name this new organization, would own each of the parties' current contracting entities, BIDCO, Leahy Clinical Performance Network, and Leahy Clinical Performance ACO. And the new entity would be expected to contract on behalf of all of the hospitals and physicians that currently contract through those groups today. So that includes, as you see on the bottom left, Cambridge Health Alliance, Lawrence General, and Metro West Medical Center. I'll note here that Metro West, you see it's grayed out and in italics. It is a member of BIDCO, will have the opportunity to participate in BIDCO contracts. It is not currently participating in BIDCO contracts, so we wanted to reflect that. And I'll note actually throughout our report, we have generally erred on the side of trying to be conservative. So for many of our market analyses, for example, we actually exclude Metro West, given that they're not currently in BIDCO contracts today. And then the last component of this transaction is that MCIPA, the Mount Auburn Cambridge Independent Practice Organization, would be joining the contracting network of this new entity. It would remain corporately independent, but it would participate in the design of that entity and contract through that entity with payers going forward. On this next slide, you see an org chart simply showing that Beth Israel Leahy Health would become the sole corporate member of each of the hospitals that we just discussed. It would own the Leahy contracting arms as well as BIDCO, and MCIPA, as discussed, would be a member of the new systems contracting entity, but would only be a contracting affiliate, not owned entity in the new system. And finally, just recognizing that these relationships are a bit tricky, showing it yet another way. So this chart just shows the current corporate affiliations and contracting affiliations of each of the different entities, both the parties to the corporate merger and the contracting affiliate hospital systems today, and what their relationships would be post-transaction. These next few slides are really just summaries of each of the parties coming into the transaction. BIDMIC, as you know, is one of the largest systems in the Commonwealth, the third largest by net patient service revenue, the second largest by total net assets. In addition to its 669-bed Anchor Academic Medical Center, it owns 3 community hospitals in Milton, Needham, and Plymouth, as well as some physician practices. Financially, the system is strong. At the end of fiscal year 2016, BIDMIC had an above-average reserve of days of cash on hand, a high current ratio, low debt-to-capital ratio relative to other large Massachusetts provider systems, and it generated a positive operating margin and total margin for every year since 2012. It does have a slightly older age of plant than other comparator systems, so I do just want to acknowledge that. That does suggest the potential need for capital investment in the future. All of the BIDMIC owned hospitals and physician practices contract with payers through the Beth Israel Deaconess Care Organization, or BIDCO, along with a number of non-owned contracting affiliate entities. As we discussed in past reports, BIDCO has grown substantially in recent years and now includes more than 2,500 physicians and 9 hospitals. Seacoast Regional Health Systems is the parent organization of Hannah Jake's Hospital, a 140-bed hospital in Newburyport that is also currently a member of BILH. Seacoast is a small provider system which has experienced some financial difficulties in recent years, including a small negative operating margin in fiscal years 2015 and 2016, as well as a large decrease in net assets from 2014 to 2016. New England Baptist, which also contracts with payers through BILH, but which would be owned by the new Beth Israel Leahy Health System, includes a 100-bed orthopedic hospital and approximately 125 physicians. New England Baptist has maintained modest but positive operating margins and total margins for the past several fiscal years and is financially stable despite a small downturn in NPSR in the most recent fiscal year, which I'm leading for. Leahy is the 5th largest provider system in the Commonwealth by net patient service revenue across all of its own entities. It owns 3 hospitals, the main Leahy Hospital and Medical Center, Anchor, as well as Northeast Hospital, which includes separate campuses for Beverly Hospital, Addison Gilbert Hospital, and Bay Ridge Psychiatric Hospital, as well as Winchester Hospital, along with 1,200 physicians and a handful of other providers, including Leahy Health Behavioral Health Services, some urgent care centers, and some home health and skilled nursing providers. Leahy maintained positive total margins for fiscal years 2012 through 2016, with the exception of fiscal year 2015 when its margins shrank and it experienced an operating loss. But documents provided by the parties in the course of our review indicate that Leahy also experienced a substantial operating loss in fiscal year 2017, though it expects to break even in fiscal year 2018. Finally, the last of the hospital systems that will be owned by the new Beth Israel Leahy Health System is Mount Auburn Hospital, a 223-bed hospital in Cambridge that currently contracts with payers in the payment plan. Mount Auburn, despite been a financially stable organization, the documents provided by the parties here show that Mount Auburn experienced operating losses in fiscal year 2017, but expects to break even in fiscal 2019. The Mount Auburn employed physicians, along with a number of other physicians, currently contract with payers through MCIPA. As a reminder, MCIPA would not be joining the Beth Israel Leahy Health System as a corporate member, but is anticipated to contract with payers through the new system going forward and participate in the design of its contracting arm. This slide summarizes some key statistics about what the resulting Beth Israel Leahy Health System would look like after the proposed transaction. Like partners, Beth Israel Leahy Health is expected to include 13 hospitals in Massachusetts between its corporate members and its contracting network. It would account for 22% of the staff beds in the state, which is actually slightly more than partners, 19% of physicians, 15% of PCPs. And in addition to being second in size to Leahy Partners, it would also be second in size to Leahy Partners in terms of its net patient service revenue and net assets. It would have an approximate $4.8 billion in net patient service revenue as compared to Partners' 7.6, and 2.65 billion in net assets as compared to Partners' 5.74 billion. It would also serve a large geographic area as shown on the map here, which is the union of the different inpatient primary service areas in each of the participating hospitals. As with all transactions, we closely examined the parties' plans for the new system, including plans for quality improvement, clinical integration, and changes to or expansions of service. I want to acknowledge that the parties are engaged in a robust planning process with more than 30 working groups developing recommendations across many different areas, including the ones you see bulleted on the slide. However, in all cases, the parties have emphasized that their planning process is ongoing. While some of their materials are detailed, none of their proposals are final, and most have key details like timelines, targets, and funding commitments that have not yet been determined. We've heard that there may be some practical reasons for this, For one, there are certain legal restrictions around what confidential data can be shared between corporately independent entities. And additionally, the Beth Israel Leahy Health corporate organization that would need to approve any final plans obviously does not yet exist. For this reason, though, you'll see throughout this presentation and the report that there are a number of pieces that we simply cannot yet evaluate on the basis of the parties' plans, which are still under development. Notwithstanding the fact that the planning is ongoing, the parties have laid out a number of goals, as you see outlined on this slide. In particular, they've highlighted that they seek to expand their geographic coverage and services to be more attractive to payers and employers. They seek to shift care from higher cost to lower cost providers to achieve healthcare savings. They want to work with insurers to create innovative insurance products. They want to build on their individual quality improvement strategies, and they want to generally expand access to community-based services. Before we turn to the key findings in the report, I want to pause there because I've gone over the parties to the transaction and the goals of the transaction relatively quickly. Are there any questions about that before we move on? Great. Hearing none, we will move on to the next section.
As we move on to the next section, I just want to swap out one person here for us and invite up Dr. Corey Capps. Dr. Capps is our primary economic consultant for the Health Policy Commission, works as a partner at Bates White, one of the nation's leading consulting firms in this area. Dr. Capps, along with his team, worked with our team on a number of these analyses and is here to answer any technical questions that we may have as we go through this.
So I do want to just acknowledge up top for those who recall how we've done our cost market impact reviews in the past. We have frequently broken out a discussion of baseline performance of entities from a discussion of impact. Given the interrelatedness of each of these components in this transaction, we're presenting the baseline and the impact together. So you'll see that we'll present all of our findings on cost and market, then on care and delivery quality, and then on access. So diving right in on cost and market. On this first slide, you see actually a new metric that is creating a system-wide average, a weighted average, of the inpatient relative prices across system hospitals of the Beth Israel and the Leahy system. Here you see that across their hospitals as a whole, the Beth Israel Deaconess Medical Center system is generally the second highest priced. Comparable, and it is comparable. I'll note that we don't have this in the slide deck, but in the report we show this on the outpatient side. Beth Israel Deaconess is comparable to other non-partner systems on the outpatient side. Leahy is comparable to other large systems, Steward and Wellforce, both on inpatient and outpatient services. When we looked at individual hospital prices, we found that the parties are generally low to moderately priced. This chart is just showing one example payer, but it is representative of what we see across payers. Here we found that hospitals that have been recently acquired or which have recently affiliated with the BIDCO or Leahy networks have not actually increased their prices after affiliation, and so I do want to note that recognizing that these systems have recently grown, we did want to see if prices have changed over time, and generally we don't see that there has been an increase relative to comparators. These positions have been relatively stable. That said, I do also want to acknowledge that those past transactions have been a fair bit smaller than the transaction we see before us today. They've been the acquisition or affiliation of a single hospital at a time. By and large.
Okay, just a technical question, if you flip back to slide 63, under the last bullet point, that the system-wide prices have not risen relative to comparators. Which comparators did you look at there?
So the same comparators that you see on the slide here, but these positions have been stable over time. Obviously, I talked about that with regard to the individual hospitals. That's also true, as you noted, at a system-wide level, that their system prices have remained relatively stable relative to comparators. Obviously, everybody is going up over time, but if you look at the adjusted prices of everyone, they're relatively stable.
Okay, just to be clear, you, in the initial summary, you talked about a number of these hospitals gonna be the contracting agencies, like BIDCO would do their contracting. But it doesn't mean that all the hospitals get the same rate. Is that fair to say?
That's correct. So different contracting networks have different patterns. And so we have not seen that either the BIDCO network or the Lakey network has tended to have level prices for all of the hospitals in their network. We do see, however, that they tend to have uniform prices across their physicians.
Okay, that's important. So as you talk about it, because it gets very confusing when you start talking about an independent, one contracting agency. It could, so thank you for that.
When we looked at spending, we found that the parties have generally had moderate health status adjusted TME compared to other systems in the Commonwealth, all within 4% of network averages across each of the major payer networks. And we also examined annual growth of each party's HSA TME, the three largest commercial payers, to evaluate their performance over time, and found that BIDCO and Lakey have generally experienced changes in their health status adjusted TME that are in line with general trends across the market.
When you mention spending, since some of these organizations are physician-only organizations, I assume you're including in there the hospital expenses for their patients?
Yes, so that's a great flag. So health status adjusted total medical expense is a metric that we use in a number of pieces of our work. It is all of the spending for the patients who are attributed to the PCPs of each provider network. And so that is regardless of where they may be seeking care. So an Atrius patient may seek care at a hospital. Obviously, Atrius does not have hospitals in its network. All of that hospital spending is also attributed back to Atrius in the health status adjusted TME. And the health status adjusted TME also includes things like pharmaceutical spending. It is obviously health status adjusted to try to provide some comparability between providers who may have different risk profiles.
So Kate, just to be clear on that, attributed physicians, so can you talk about all spending versus that which you can actually account for that's attributed?
Absolutely. So the health status adjusted TME metric is defined by CHIA to measure spending for those patients who are participating in a product that requires them to designate a PCP. So these are largely HMO POS patients. It does not, by and large, include PPO patients. That said, we also ran a sensitivity of this with the APC, with the All Payer Claims Database, which includes both HMO and PPO patients. In the APCD, it's claims-based spending only, so we don't get some of the non-claim spending that we get in the health status adjusted TME, but we actually find very consistent results. So we feel confident in stating that the parties are moderately, their spending is moderate for their patients of their PCPs, whether you look at it through the health status adjusted TME metric, looking only at the HMO population, or you're looking at the All Payer Claims Database for patients that we are able to tie back to the PCPs, and that includes in the PPO market.
Kate, can I take back to slide 64 for a second?
Sure.
I don't understand the slide. So when you say comparator, these are similarly situated. No, 64, not 63. Yes. Sorry, don't quite get the slide. So a comparator is a similarly situated hospital.
Yes, and so the way that we define comparators, and I apologize that the slide doesn't include the whole list because it's a little unwieldy, but it is listed out in the report. We looked at the patients living in the primary service areas of each of the hospitals that were focal hospitals and the other hospitals that were providing services to patients living in that geographic area who also had a similar level of acuity. So even though an AMC might, for example, be seeing patients from a primary service area of a community hospital, we limited it to community hospitals also seeing patients from the same geographic area as that community hospital. And then obviously if we were looking at AMCs, we limited it to AMCs, et cetera.
So Kate, I answered that question too.
Yeah.
What would be, for example, the comparators to New England Baptist? I mean, they're a specialty hospital.
That's
Their specialty hospital, I couldn't think who the comparators would be.
That is an excellent question. So we actually defined their comparators two different ways for exactly that reason. And so we, in some ways, New England Baptist acts as if it acts like an AMC. So you see that we included them in the AMC column along with BIDMIC and BILH. We also included them in their own column to the right of that, New England Baptist and community hospital comparators. These were defined to be community hospitals that were serving a large number of orthopedic patients, and so we defined it that way. I'll note we also ran a sensitivity of this as well. And so here we actually did a cut of the All Payer Claims database, just looking at orthopedic services and the pricing for orthopedic services at various different hospitals, and found a comparable pattern that New England Baptist tends to be low to moderate price, depending on whether you're looking at AMCs or community hospitals providing orthopedic services.
This also, so CHA Lawrence General Metro West are the lowest of all.
Correct, and so in general, we do see that the BIDCO network, community hospitals, both the owned hospitals and the affiliated hospitals, tend to be relatively low priced in comparison to other community hospitals. So recognizing that these parties have grown in the past, and obviously we looked at prices over time and spending over time in part to see if their growth had appeared to have driven changes in the past. We also wanted to look at the parties' claim, both in this transaction, that they will be able to reduce outmigration to costlier sites of care and keep care local at a reduced cost, alongside the claims that have been largely identical that they've made in past transactions, that they've been able to keep more care local and thereby reduce costs. As we'll show in more detail on the next slide, we found that the parties have had some limited success at retaining community appropriate care locally at their recently acquired community hospitals. But in many cases, their anchor teaching hospital saw a greater increase in its share of community appropriate care from the local service area that the community hospital did. And I'll walk through that on the next chart. So this chart is a little bit tricky to read. So what this chart shows is looking at the year prior to an affiliation with either the BIDCO network or the LAHEE system, a hospital's share of local community appropriate discharges compared to its share of local community appropriate discharges in the most recent year of data. So the blue line shows how that community hospital's share has changed. The green bar is actually the comparison bar. So the green bar is how community hospitals generally have seen their share of community appropriate discharges in all cases decline in the same time period. And you'll see that green bars are different because each of these are different time periods. The red bar is the change at the anchor hospital, its share of community appropriate local discharges during the same time period. So if you look to the far left, you see that Anna Jakes, between the time that, prior to affiliating with BIDCO to present, it lost 5 percentage points of share of community appropriate discharges in its local service area. Meanwhile, BIDMIC, the anchor hospital, ticked up a bit, a little under 1%. The loss that Anna Jakes experienced was greater than the loss that community hospitals generally across the state were experiencing at the same time, as you see in the green bar. You see a similar pattern for the 3 hospitals on the left of this chart. Anna Jakes, Cambridge Health Alliance, and Lawrence General all lost shares of community appropriate volume at a greater rate than the state as a whole in the time period being examined. And for 2 of the 3, Anna Jakes and Cambridge Health Alliance, the anchor actually gained shares during this time. Those 3 hospitals are all contracting affiliates. On the right side of this chart, you see a very different story for the 4 hospitals that were actually corporately acquired. So starting in the middle with BID Milton, you see that BID Milton saw a small uptick in its share of community appropriate discharges from its local service area, while if you compare to the green bar, community hospitals generally were losing a fair bit of share. However, you do see that BIDMIC, the red bar, experienced an even greater increase. Moving over to the right, you see Winchester has a similar story that while it had an uptick, Leahy's uptick was even greater. Northeast, it's a little bit closer to each other, but still Leahy's uptick was a little greater. And only for BI Plymouth do you see that the community hospital gained a share that was far in excess of that the anchor hospital did. We ran this a number of different ways. We do get slightly different results, whether you're looking at, this is all payers, and this is community appropriate discharges. When you look at higher acuity discharges, you do see slightly different patterns for a couple different hospitals. And when you look at commercial only discharges, here too you see some slightly different patterns. But by and large, the story remains the same, that even where the parties gained some share locally, they were generally gaining it at both a community hospital and at the anchor. And their performance in general with owned corporate members was superior to that of contracting affiliates.
So Kate, this is something that we should come back to and discuss in the discussion period. I think it's a technical question. In your opinion, as you looked at these data, since we're just seeing the aggregates, could this have been an effect of the newness of the incorporation and the affiliations, that these hospitals just haven't had time to recalibrate their admissions and discharges? Or do you feel that these data are historically solid enough so that they're a predictor of the future?
I think it's hard to draw incredibly firm conclusions from any of this. This is certainly preliminary, and we're looking at before and after trends, recognizing that for many of these we don't have many years of data, as you accurately noted. That said, I would say that Winchester and Plymouth are not on vastly different timelines than the contracting affiliates you see on the left. So while that might be true of Milton and Northeast that were acquired more years prior, there isn't so great a difference in acquisition time between the other hospitals, Winchester, Plymouth, and the 3 contracting affiliates.
What year's the data from?
So it was looking at the year prior to affiliation to present, and so I believe the earliest year we looked at for any of these was 2011. It was 2011 data, and then it's comparing to 2016, which was the most recent data that we had at the time.
Thank you.
So in each primary service area or PSA where we saw that after a transaction, BIDCO or Leahy hospitals gained volume, we then looked at where that volume shifted from and found that wherever the parties increased their share, the shares of both higher and lower priced hospitals decreased. So share was coming from both their higher priced and lower priced competitors. And as we saw on the previous slide, the BIDCO and Leahy hospitals that gained shares after transactions generally included a mix of both the community hospital and the anchor hospital. Obviously, the community hospitals by and large being lower priced and the anchor by and large being higher priced. As a result, the overall effect of these different price changes, the overall effect on commercial prices was somewhat mixed. So in 3 of the primary service areas where BIDCO or Leahy gained shares after a transaction, commercial payers on average ended up paying a somewhat reduced price. While in the other 2 PSAs where BIDCO or Leahy gained shares after a transaction, commercial payers on average ended up paying a somewhat increased price. Jumping ahead to the next slide, likely as a result of these mixed effects on price, combined with the fact that the overall volume of shifts has been small, and the net price differentials, even where there were savings, have tended to be small. We don't see that spending trends consistently improved for patients after their local hospital was acquired or affiliated with BIDCO or Leahy. Out of all 7 of the transactions we looked at, in only 1, Northeast, do we see that post-transaction spending trends were generally better than relevant averages across all 3 major payers. Any questions before I move on?
Question. I'm just trying to reconcile the one from 68 to the graph on 67. So it says that specifically, I would think that you note that the volume shifts for BID Plymouth resulted in higher commercial payments, whereas previous slide would suggest that there was more community appropriate discharges. How can you just talk about how you connect those 2 dots?
Yeah, so a couple different things. So first of all, I'll note that we wanted to show the all payer trends in the chart. And so the all payer trends are what you see in the graphic. Whereas when we calculate price differentials, obviously the price differentials exist in the commercial space. So we were only limiting the data set just to commercial. So the trends are slightly different in the commercial space. That said, it's important not only where the patients went to, but where they came from. And so where hospitals that were losing share were significantly lower priced hospitals, that could lead to price increases, even where the community hospital was seeing an increased share.
Do you have data on the volume of admissions as well? Were there major shifts there?
We do have those data. I don't know that I have it on me at this moment, but I can certainly follow up with you after the meeting. By and large, the volume shifts are relatively small.
Small.
I mean, the figures that you see on the chart are changes in percentage points. So in many of these service areas, we're talking about a change from 12% share to 10% share. And so, when you actually calculate it in terms of discharges, we're not talking about extremely large numbers.
So could you go back to 67? I want to make sure I'm not presuming anything. So would you go across the bar and tell me which of the anchor teaching hospital is for each of them? So the anchor teaching hospital for Annie Jakes.
Oh, sure, I'm sorry, yes. For Anna Jakes, it's BIDMIC. For CHA, it's also BIDMIC. For Lawrence General. For Cambridge Health Alliance, the anchor was BIDMIC. For Lawrence General, the anchor was also BIDMIC. For BID Milton, it's also BIDMIC. For Winchester, it's Leahy. For Northeast, it's Leahy. And for BID Clement, it's BIDMIC.
That's right, the Cambridge Health Alliance, which is not supposed to not be the same for Cambridge Health Alliance.
I'm sorry.
Cambridge Health Alliance is a teaching hospital, but they're not the PSA for Cambridge Health Alliance. Well, that's teaching hospital, doesn't say that.
Oh, the anchor teaching hospital of the system. Yeah, you're correct. That's probably a non-ideal labeling on our part. Thank you for clarifying that. We will take note of that. Great. So these next few slides really mirror slides that we've shown probably in the past. Consistent with our past reviews, we looked at the parties' shares of services in relevant geographic areas. Here we show their statewide shares of inpatient and outpatient services, showing that post-transaction, Beth Israel Leahy Health would be a close second partners in terms of its statewide shares of inpatient and outpatient services, and it would have more than 3 times the share of the next largest competitor. When we looked at adult primary care services, we found that post-transaction, the Beth Israel Leahy Health System would actually have a greater share of these services statewide than partners. Of course, for both this chart and of the previous, those are statewide shares. We also looked at shares in specific service areas, and those are included in the report and in the data appendix. And as one might expect, we find that the parties would have even greater share in many of their relevant service areas. We also, and I'll note this is also in the data appendix to the report, we looked at some key service lines, orthopedics and maternity care in particular. There too, we find that the parties would have a very significant share, both statewide and within relevant service areas. Consistent with our past reviews and with our statutory charge, we also looked at changes in concentration in the parties' primary service areas using the Herfindahl-Hirschman Index, or HHI. The DOJ and FTC used changes in HHI and PSAs as screens for determining whether a given transaction raises competitive concerns and warrants further scrutiny. The key threshold here is really the bottom row, where the resulting HHI from a transaction is greater than 2,500 and the change in HHI is greater than 200, transaction is presumed likely to enhance market power and is generally warrants further review. When we looked at HHIs by primary service area, we found that a number would be over this threshold as highlighted in red on the chart below, including the primary service areas of proposed BILH-owned hospitals, BIDMIC, Anna Jakes, Leahy Hospital and Medical Center, Winchester, Northeast, and Auburn, as well as the contracting affiliates, Cambridge Health Alliance and Lawrence General. Initial analyses also indicate significant increases in concentration for specific inpatient service lines, such as orthopedics and some outpatient services. Recognizing the scale of the proposed transaction as well as our growing analytic capacity, both internally and with our contracting consultants, we also ran a new set of analyses in this transaction, willingness to pay analyses in concert with Corey Capps and his team. And so I will turn it over to my deputy, Megan Wolf, and Corey Capps to walk through what we did and our findings.
Thank you, Kate. We completed a willingness to pay merger simulation to predict the likely outcome of the transaction on the parties' bargaining leverage and prices. Antitrust agencies have increasingly relied on merger simulations rather than solely on market shares and related statistics in healthcare merger cases. Willingness to pay is an econometric model that quantifies bargaining leverage by estimating the value of a hospital or system to a payer's network, measured as the difference between the value of the payer's network with and without the particular hospital or system. For example, as long as two hospitals are close substitutes, such as hospitals that are located near one another and provide many of the same services, a network that includes just one of them may not be dramatically less attractive than a network that includes both. Thus, a payer might not be willing to pay either hospital particularly high prices. In other words, this competition between alternative hospitals maintains lower prices. But after a merger of these two hospitals, excluding both hospitals would substantially reduce the value of the network because patients would be forced to choose a third, less preferred option if both were excluded. Thus, the payer would be willing to pay more for both hospitals together than it would for each of them individually prior to the merger. For this transaction, we calculated the value of the parties' hospitals to payer networks, or their willingness to pay, pre- and post-merger, using a hospital choice model, which estimates the importance of a hospital to individual patients based on factors such as diagnosis, severity, drive time, and the services the hospital provides. The difference between the willingness to pay for the party hospitals before and after the transaction represents the parties' increased bargaining leverage due to the merger. We then performed a regression to calculate the relationship between a hospital or system's willingness to pay and its prices in Massachusetts. We used the parties' change in willingness to pay to estimate the price increases the parties would be able to obtain as a merged entity. Our willingness to pay methodologies are consistent with those used by antitrust agencies in recent healthcare merger cases. The inpatient willingness to pay analysis yields a projected one-time inpatient price increase of 5 to 6.7%, which would result in an annual spending increase of $38.3 million to $51.4 million for inpatient services. The outpatient willingness to pay analysis projects a one-time price increase of 8.4 to 12.2%, which would result in an annual spending increase of 88.4 to 128.4 million. These one-time price increases would be in addition to those the parties would have received absent the merger. We have included the chart in the lower right corner here to illustrate the impact of these one-time price increases. Such increases could occur in a single year, but could also be implemented incrementally over several years, for example, over a 3-year contract term. The one-time price increases would permanently raise the baseline price levels of the parties and result in annual spending impacts shown here.
Nikki, can I ask a question there? These percentage increases that you're talking about are way above our spending benchmark, right, of 3.1, which I have to think plays an important role in the negotiations between the payers and the providers. So is that correct? And how would that interplay maybe affect the numbers that you're showing here?
It's a great question, and I'll start, and then I would love for others to jump in as well. So one thing is, it's important to note that these wouldn't necessarily happen in 1 year. They could happen over a contract term. And so, for example, 5 to 6.5% increase could be achieved through a 1.5% rate bump over what they would have otherwise gotten over a few years, compounding to reach that 5 to 6.5% level. That would be less likely to run afoul of the benchmark. Also, obviously, we monitor spending through health status adjusted TME, which, as you may recall in the conversation we just had responding to the question from Dr. Kreider, the health status adjusted TME measures that we look at are tied to the spending for the HMO population. And it's all of the spending for the attributed patients. So while price increases at one provider will impact their TME, it will also impact the TME of other providers, and it's only on the HMO side that we're currently monitoring it. And so the parties could potentially load price increases into the PPO side or find other ways to potentially achieve price increases that would be less likely to run afoul of the benchmark.
Kate, this may be a mistimed question, but this is an analysis of the effect of price leverage on consolidation of these parties. Undoubtedly, part of the claim is that the current dominant player, partners, would be affected by this new competitive, more powerful competitor. What is there? Does willingness to pay tell us what's going to happen in the market as a whole? Would partners' prices go down to compensate for this new competitor, or is this consolidation and willingness to pay just operate independently of that?
So I'll start and then I may ask Corey to jump in as well. So the merger alone doesn't change the bargaining leverage of anyone else. The willingness to pay analysis is summing up the market shares of the parties as they currently exist. If the parties, and we'll talk about this in a few minutes, if the parties make themselves more attractive to patients such that they further increase their volume and thereby decrease some of partners' volume, they could chip away at some of partners' negotiating leverage. When we've modeled it, we find that those effects would be pretty small. And by taking patients away from partners, it would be taking those patients to Beth Israel Lahey Health, which would further increase their bargaining leverage beyond the numbers you see here. And those spending effects would tend to cancel each other out. So there's not really much room to achieve substantial savings that way based on what we've seen.
Yes, I asked about the willingness to pay model. So from the point of view of the BIDMC Lahey merged entity, is there any part of the model that says they would keep their increases down in order to increase that dynamic rather than take full advantage of the willingness to pay difference? Would it be smart competition for them to say, we're not going to take that full 6.7%, we're going to keep it lower to get more share?
I would say on that point, this is a projection, this is a model for what may happen, and certainly it is future looking, so we don't want to prescribe that these are certainties. The parties have stated that they do seek to close the gap between themselves and partners, and have not stated what level of price increases that they would be seeking.
I would add that the parties are already in most of the networks, right? So patients have a strong incentive to, or if they're in network, patients have an incentive to choose them that's independent of the allowed amounts that they negotiate with health plans, right? It's just determined by the plan benefit structure. So in order to get more patients post-merger, they're going to have to do something to improve their perception, improve their brand, improve their facility, anything like that. Most of those things probably take money, so yeah, they may be linked to the price effects.
Kate, this may be a question to Corey. It seems to me that both the willingness to pay increase and the annual negotiated increase are part of the negotiations that any provider has with a payer. Kind of how often, when you have a situation like this and you're looking at the one-time willingness to pay, is there some sort of a compromise between the two? We're looking at them here as just being separate and additive. Are there times when there's a negotiation that says, well, I think this goes to what Don was saying, well, we'll only take half of the willingness to pay or half of the annual increase? I'm trying to gauge how rock solid this hypothetical projection is.
Well, certainly going into the negotiation, each party, the payer and the provider system, will start with their objectives, and probably at the end they're going to come out somewhere in between what each side wanted. So the payer may want 1% in the next contract, and the parties may want 8%, and they're going to come out somewhere in between there. So there's always negotiation. There can be trade-offs between inpatient and outpatient, so you may get a bigger increase in one area or another. Kate alluded to potential differential increases in HMO and PPO, so there are a lot of factors and room for compromise. The aspect that the willingness to pay is really measuring is how much additional oomph in the bargaining negotiation do you get from the ability to say, hey, payer, you can't have all three of these systems, Joe County, Mount Auburn, unless you agree to our terms, versus right now, today, each system has to go in and say, well, you may not get Midco hospitals, but I can't control whether or not you strike an agreement with Leahy and Mount Auburn. So that's the one dimension of a much broader and more complicated negotiation that's being measured with this metric analysis.
Could we look at it another way as well? Right now, you have partners that's the highest priced of the hospital systems, and you have these hospitals that are emerging, they're middle of the road. And we have this benchmark at 3.1%. And let's assume, for the sake of discussion, pricing in the health industry goes up around 3.1%. And that includes partners as well as Beth Israel Leahy. And now you add the other 5 to 7% that you mentioned in terms of willing to pay. Even at that level, if I'm correct, their pricing, NUCO's pricing, is still below partners and still provides them with a competitive edge there from a pricing perspective. Is that correct?
Right, the gap shown in the earlier graphs is large enough that each of the merging parties or the merged system could raise its price and still be less expensive than partners, but as I think we'll see in a little bit, that will be spending increasing if patients don't change their decisions at all. It will be spending decreasing to the extent patients go to the parties' hospitals instead of partners, and it may be spending increasing to the extent that the patients go from a non-partners hospital to one of the parties' hospitals. And so the analysis pulls all of those into the spending impact.
At this point, you may want to show the slide with the bar. You have it in it. Because I think that tells the story that Ron better than any I've been able. This is why we get confused. So
144.
what is,
I don't think this is another copy. It's your copies.
what this shows, Ron, is assuming at the low end, there is a 22% currently differential between the average pricing at partners and the average pricing of this combined entity. That the low price, the low estimate would increase it bridge the gap of 31%. The higher estimate would bridge the gap at 44%. So it gives you a picture for what these estimates are doing to that gap.
But that's one presumption.
That's
When
what
the
this model-
presumption, I understand. All the models that we see, economic models, which I'm a social worker, but what I hear from every economist is you can't predict what's really going to happen. You can correct me, economist, if that's an incorrect statement. Is that merger will only drive up prices. The question, I guess, and the rest of the conversation is, in the merger, can you drive down and constrain prices? But what this model does only demonstrates that market share will increase prices. That's what this model does. You don't have a model in here that shows a merger that could actually constrain.
So we did actually look very closely at the question of whether or not the growth of a second largest system can create a more competitive market. And so I'll note that the economic literature does not have a clear answer on this one. There's very little that addresses it squarely. So we looked to practical examples in the world to see if there were examples of second largest systems getting big enough to create a more competitive market. And in that work, we were only able to find one example of that occurring. And that was a very different market. And so in Peoria, and this is in the report itself, in Peoria, there was a second largest system that had been excluded from some of the largest payer networks. And by getting bigger, they actually were able to gain the market leverage to be able to be included in those networks. And so it actually led to a broadening of the networks and likely decreased the prices of the number one system. That said, we don't really know what the prices were at the second largest system afterwards, so it may not have actually been price reducing, we can't really say, but it at least broadened networks, and there's at least some potential that that one increased some degree of competition, but that was the only example like that we were able to find. And I know, Corey, you spent many hours with speaking with many different economists on this topic. Do you want to add more on kind of the growth of the second largest system?
Sure. I mean, I think the literature finds that, and this is a broad and robust literature, that mergers of closely substitutable hospitals or hospital systems tend to increase price. And there's a 2012 Robert Wood Johnson Foundation survey that's very good on that. Now, at the same time, there have been 70 to 100 hospital mergers per year for at least a decade, and very few of those are challenged, right? So it is absolutely not the case that all or even most hospital mergers are going to create significant additional bargaining leverage and raise price. So there must be some other reason that the hospitals are doing that, and that's where the other factors that you referenced live, like cost savings and potential synergies. So I want to clarify, the willingness to pay model that drives price increases is really focused on the impact on bargaining leverage and prices, and that in some sense maybe forms a hurdle against which you judge the likelihood, the plausibility, the magnitude of all the other factors. On the specific point about the literature on the second closest competitor, I mean, again, it's not well studied. Kate is correct on that. I think most standard economic models are going to find a 0 to price increasing effect from that, holding costs constant. So that may be why it's not well studied. But if it happens more commonly in the world at large, there would be a Cutler student doing well as a young professor examining that.
I've asked, I've sort of done an informal survey of the field of industrial organization economists, basically asking them exactly that question. You know, if the number two system wants to get bigger, is that on that good or bad? And it's very, very hard to get a definitive answer. What we have is, on average, when hospitals merge, prices go up. That's a very robust market. Whether that has any subsequent implication for those hospitals, depending on where they were in the pecking order, or for other hospitals that may have been more higher priced and larger, is not a question on which there's been much evidence. And I couldn't get any kind of general relationship, any kind of finding that anyone felt comfortable with about it. And so what people are saying, and I'm going to come back to this later, what people are saying, which is correct, is that the models in this case are very imperfect relative to what we would like, much more so than in past cases that we've had. And that's just an unfortunate fact of this situation.
And one final point, if I may. An insurer can absolutely today go out and build a network that does not include partners, but includes Mount Auburn, Leahy, Bidco, Stewart, Wellforce, all of those. So the merger doesn't suddenly make that network feasible. So what you have to ask is one layer behind that, what about the merger changes the incentives of the parties or the market perception or the incentives of the payers, such that that same network that doesn't have partners, for example, is now more valuable than it is right now since it already exists.
Okay, back up. It's very important.
We also conducted a willingness to pay analysis for adult primary care services, which yields a projected one-time price increase for those services of 9%, resulting in an annual spending increase of 11.5 million. The parties provide other services besides inpatient, outpatient, and adult primary care. If they were to receive similar price increases to those that we've modeled here, 5 to 10%, for example, specialty physician services, we might expect an additional spending impact of 29.8 to 59.7 million annually. This is not something that we have explicitly modeled.
Megan, why didn't we model the willingness to pay? Why are we just drawing that conclusion based on outpatient and inpatient? Specialty, you highlighted orthopedic and obstetrics as well. It is a big concern highlighted in the board.
Absolutely. So, one of the things that's important to note is just that in general, hospital data is far cleaner and easier to use than physician service data, and so just practically, we had to prioritize which physician services we wanted to start with, and for that reason, we really weren't able to get into each of the specialty physician service lines.
And I would say in the report, we do keep these things separate in terms of how we describe them, because one was based on the model, and one is, again, kind of translating those price increases to other spending. So we do want to treat them differently.
That said, I do want to acknowledge that the fact that the price increases are so close in range between inpatient, outpatient, and adult primary care services does kind of speak to the robustness of the results, and it is reasonable to expect they would probably get price increases on other services that we know they each provide that overlap as well. And so it is reasonable to expect that there would be some price increases in these other service lines as well.
And as previously noted, the parties could obtain these price increases, substantially increasing healthcare spending while still remaining lower priced than partners.
They still would be exceeding the cost growth benchmark, is that right? And there's a risk in doing that, and then, we could review that the following year, put them on a performance improvement plan. I mean, there's that dynamic that exists that could temper these price increases.
Yeah, absolutely, and I think, that being said, the benchmark is not a price cap. Right, and we have been very clear that the benchmark should not be interpreted as a price cap in negotiations, and then we've said that, I think, in multiple different occasions. How the price, if they were successful in negotiating price increases, and the if and successful, importantly there, how that may play out in terms of our ability to review those organizations through the PIPS process, I think is still unclear.
This may be a comment, and Mr. Chairman, you can chastise me for this. The benchmark has actually served a very public and useful purpose that, frankly, listening to some of this conversation around economic forecasting may be actually more accurate and beneficial than some of these economic hypotheticals, quite frankly. And this is a series of presumptions that are very important for us to go through and understand. But there are other levers that would be available to the HPC and other monitors in the event to constrain these hypothetical cost increases, which is in fact the benchmark, which is in fact the PIP, which is in fact reopening the deal and civil life. So I think this is in the context.
Can I interject here? Because I think there's a bit of confusion going on. So first of all, what they're talking about are increases beyond the normal increases that would be incurred without the merger. We tend to look at these numbers and compare them to the benchmark. That is not correct. So the way to look at this, and I would ask you to do it, normally if we have we've been very close to the benchmark increases each year, slightly above, slightly below. On average, we're just won it by 0.2. So for all practical purposes, I think it's not unreasonable to assume that without the merger, the increases, now remember, there are two parts to spending. There's the price increases, and then there's the volume increases. So a benchmark of 3 usually leads to a price increase of 1.5 to 2, but not 3.1. So now what we're talking about here are increases beyond that, beyond what the market, I don't want to keep going if I'm wrong.
No, you are correct.
So don't look at 5 and say, well, 5 minus 3 is 2. That's not, and that's not relevant. That's not related to your comment, which is what's the value of modeling anyway, which is a legitimate issue. So I'm just trying to say, when we look at these numbers, do not equate them directly to the benchmark. There are other increases going on. These are increases beyond what the market would have generated had this merger not taken place.
That's correct. And just a couple other points on the benchmark vis-a-vis modeled price increases. So we did actually work with Corey and his team to look at the relationship between willingness to pay and price over time, including since the benchmark existed. And if the benchmark were constraining bargaining leverage, we would expect to see that the relationship between willingness to pay and price would degrade with time. And we actually don't see that. It appears that bargaining leverage is still, notwithstanding the fact that we have the benchmark, is still playing a role in driving the price levels in the market. And I also just want to lay out that the other piece here is that obviously when Chapter 224 was created, the PIPS process and the CMIR process were envisioned to feed into each other. There's actually one of the triggers for a CMIR is identification by GIA as having excessive cost growth. And so I think there was at least an implicit recognition that there were scenarios where there could be market changes that could increase healthcare spending that may not be fully captured in the PIPS process. Also, as noted, there's the HMO issue that the PIPS process currently only focuses on the HMO issue. HMO side of the market. It's risk adjusted. Sometimes there are changes with a risk adjuster that even if spending is increasing in excess, the risk score is going up such that it looks like it's deflating. And I do want to note also there's a time lag that we don't get the TME data for several years. And so while there could be a price increase that's negotiated prospectively, it would actually take us several years to see it, even if it were going to be captured in the TME data.
One more technical question, or you want me to stop?
No, I don't want you to stop, because I'm prepared to go as long as but I am conscious of the time. So ask your question, but I looked at the number of slides you got here and remember where we are.
Well, quickly, the one-timeness of this is on my mind. You're talking about a step function increase in cost, but doesn't the same logic about willingness to pay affect willingness to pay for an increase year on year? So in other words, with respect to the delta, to the slope of increases, I still have more leverage in future years, and that's not one time, that's year upon year ability to get higher rate of increase in price. Is that not true?
So there was an illustrative schematic a few slides back, but that's why when it jumps up, it doesn't then go back down. So in some sense, if you have the ability to extract more, your prices go by say 5%. And then they're 5% higher than they would have been this year, next year, the year after. It's always a 5% delta, but it's not growing 5%, then 10%, then 15%, because you only get to sort of use it once. But the effect is enduring. So you kind of integrate the gap between those two lines.
Stuart, another question. Two questions, actually, macro. Are you concerned at all about the static nature of the model with regard to fee-for-service versus value-based care? So theoretically, the components could contract, locally cap, do all kinds of different things to
reduce the commercial spend. So that's number one. It's static, as I understand it, fee for service versus value-based, which is almost impossible to predict, but we all believe it's going to grow. The second is on overall spending. We're just looking at commercial. How concerned are you about overall spending as representatives of the Commonwealth, where 60% is Medicare or Medicaid, and doesn't include all commercial spending. So the GIC is carved out, right? So the model is limited by definition. Are you concerned that it doesn't capture where we're going to go in the big picture with all spending? Well, on the commercial side, but non-fee for service, it's still the case that the capitated rates, value-based programs are subject to negotiation. So I think similar factors would be at play there. You also alluded to dynamics. Now there's a really complicated economic policy question, which is, does more or less competition tend to foster greater innovation, which in this case is a movement towards value-based care and population health management, or does it tend to retard it? Schumpeter and economists to this day have been debating that, and I don't think there's actually a clear answer on that. So the two-part is, there's an independent question of whether this movement would foster the merger would foster a more rapid movement towards capitation or other global risk. And you have to look at whether small hospital systems are already doing risk and asking whether it's necessary to have that scale. Are the largest ones in the Boston area doing more of it than other hospitals systems? So those are some of the questions that come to my mind. But bargaining would still matter in a risk world, because you could be paying $300 a month for every member, or you can be paying $310 or $20.
And to the other part of your question about spending in other realms, so I want to be clear that group insurance commission data is included in the commercial spending data that we're talking about. So this is not excluding the group insurance commission. We have focused on the commercial insurance market, however, because that is where prices are negotiated. Obviously, not all hospitals get exactly the same rate in Medicaid and Medicare, so there could certainly be spending impacts there, but the differentials just tend to be far less than they are in the commercial space.
Why don't we move on?
The parties expect to achieve savings through a number of care redirection efforts, both by gaining new volume from other providers and by redirecting care within their system from higher priced to lower priced settings. Because the parties' care redirection plans are still in development, we were unable to determine the likelihood that they would achieve these shifts post-transaction. Instead, we modeled the likely scope of savings if they were to achieve their care redirection goals, and found that on balance, these shifts would be cost saving. However, even if the parties achieved their care redirection goals, the savings would not offset the increases in spending due to the projected price increases we just discussed. The parties expect to obtain new volume primarily by reducing leakage, that is, the care their primary care patients are currently receiving outside their system. We found that reducing leakage would result in shifts from higher priced as well as lower priced providers, and on balance would be cost saving. We modeled the savings the parties could achieve if they recapture leakage in line with their projections. We found potential savings of approximately 4.8 to 6.9 million at the parties' current prices, this is annually, or 2.4 to 4.5 million if the parties obtained the projected price increases. To understand the upper bound of potential savings from reducing leakage, we modeled the impact if the parties eliminated all of their hospital leakage. And I want to state that this is not a goal of the parties. But we found if they reduce all of their hospital leakage, this would result in savings of 25.8 million annually at current prices, or 13 to 16.7 million with projected price increases. The parties also plan to shift some inpatient care within their system from BIDMIC and Leahy Hospital and Medical Center to Mount Auburn and Anna Jakes. If the parties achieve these goals, it could result in annual savings of $2.1 to $3.1 million at current prices, or 1.8 to 2.8 million with the projected price increases. The parties also expect to receive modest additional volume from new patients due to greater consumer awareness or brand as a result of the transaction. We used the hospital choice model described earlier to predict if the parties' attractiveness increased enough to draw their expected additional volume, where the new patients would be drawn from. We then calculated a spending impact of these patient shifts. We estimate that more than half of the parties' new volume due to enhanced consumer awareness would come from partners, 13.5% would come from Wellforce, 9.7% from Steward, and the remainder from other providers. On balance, we found that these shifts would be cost saving. If the parties achieve their predicted new inpatient volume, we would expect just under $1 million in savings annually, between $1 million and 1.8 at current prices. If the parties achieve similar savings for outpatient services, we would expect $900,000 to 1.7 million annually in savings at current prices. And as you can see on this slide, these savings would decline somewhat with the projected price increases. The parties also expect to attract new primary care patients and recruit new primary care physicians. We modeled the potential savings the parties could achieve at current prices and utilization levels, and estimate that for each patient they attract, spending would decrease by $32 per month.
Thank you, Megan. So I think it's important to note that the projected spending increases that Megan just went through are actually likely to be conservative. There are other unmodeled factors that could also increase spending. So the first one that you see highlighted here is cross-market effects. So the willingness to pay model really focuses on the attractiveness of different providers to patients. Where two providers are close substitutes from the perspective of an individual patient, willingness to pay analyses will predict that the merger between those two providers will generally increase prices. And where two providers that are merging or begin contracting jointly are not close substitutes for patients, a willingness to pay analysis will generally not predict a significant increase in their bargaining leverage. However, in practice, decisions about purchasing health plans and thus choosing a provider network are more often made by employers rather than individuals. And where an employer is choosing a plan, they may seek to ensure in-network access to geographically dispersed hospitals for employees that commute in from multiple different areas, for example. So even though a patient may not, for example, view Beverly and BI Plymouth as substitutes for each other, an employer with employees in both regions might actually view that as a substitute. And so that could actually confer bargaining leverage on a system that has a fair geographic reach, just like the transaction that we see before us. So there have been some economic literature on this effect, and that literature has found that those effects can be quite substantial. So, for example, one study investigated the effect of in-state mergers like this one, where there were hospitals that were 30 to 90 minutes apart and found spending increases of 6 to 10%. And that was not a willingness to pay. That was looking at post-transaction. Well, we didn't model this effect ourselves. The parties noted that or have observed that their geographic reach will make them more valuable to employers, which seems consistent with the concept that cross-market effects could come into play here. Additionally, we've referenced this a few times, but just to be clear, the willingness to pay model that we did here is based on the volume that currently exists at each of the hospitals today. the parties actually have an explicit goal of increasing their volume. Increases in volume will increase bargaining leverage, increase their ability to negotiate for even higher rates. None of that is modeled in the numbers that you saw previously.
You're gonna, Kate, I hate to say this, but you're gonna have to decide if among all the stuff you put in, which is phenomenal, which is you're going to bring this.
Great, we will go very quickly. So we already spoke a little bit about whether or not this would mitigate partners' bargaining leverage, so we can likely skip past that point. The other point that the parties raised that I just want to quickly address is that they believe that innovative products, insurance products, will enable them to create a more competitive market. Here we want to note that there are already limited network products in the market that include the parties and exclude partners. So it isn't necessarily clear how there would be savings from cutting out other largely lower priced providers from a network. And while an improved new brand at the BILH system and care coordination may attract more patients to a focused limited network, that's really something that we actually modeled as part of the brand enhancement work that Megan went over a minute ago. And overall, that scope of savings is relatively small. That said, if the parties were to offer lower prices in these products, we do think that there really could be a potential. They could actually reduce spending and encourage other providers to lower their prices. That said, we haven't heard any plans from them to date to offer lower prices in any such products. Finally, I just want to note on the operational efficiency side, the parties have identified potential efficiencies of 1.5% to 3%. As noted up top, many of their plans are still under development, so we can't comprehensively analyze this, but it's worth noting that overall, it seems to be based on conservative assumptions and is not an unreasonable figure, so do want to note that. However, they expect to retain those operational savings within their system, and their own financial projections show that they expect positive financial margins through a combination of these operational savings and expected new volume and some other mechanisms without significant price increases as a result of the transaction. So that's really the cost and market section. These couple slides just summarize everything that we just went over. I will pause here before. Okay, great. Well then, thank you, Corey, for your time, and I will switch off with Sasha Snuff, who's going to walk us through our quality and care delivery findings.
Sasha, you're gonna have to hit the highlights here.
I will do my best while giving appropriate sharing to these important points. So as you know, in all of our cost and market impact reviews, we review party performance on a broad set of nationally recognized quality measures across the domains of process, outcome measures, and patient experience measures. Noting, of course, that quality measurement is always a field that is constantly in development. Examining the performance of the parties' hospitals and physician groups across a broad range of measures, we generally found that the parties' hospitals and physician groups tended to perform in line with Massachusetts state averages across most measures, with some variation in performance by measure and by group and hospital. This slide identifies some particular points on hospital performance on outcomes and process measures. We also noted that the party hospitals performed notably better than average on patient experience measures overall. And we also examined the parties' performance on these measures over time and found that generally the parties' performance on these measures improved in line with state average improvement across the measures that we examined. In terms of physician quality, we reviewed the parties' performance on HEDIS measures using 2016 payer quality reports for both the parties' physician networks and for the physician networks and several other large Eastern Massachusetts physician groups. Here we compared against the NEPA 75th and 90th percentile benchmarks, nationwide benchmarks, and found that the parties hit those benchmarks, the 75th percentile 3/4 of the time, the 90th percentile about half of the time. Performance of other large Eastern Massachusetts physician groups was similar. In a few cases, other groups hit measures more often than BILH or Leahy, but few groups hit those benchmarks as often as McKiva. We also reviewed performance on adult ambulatory care, primary care patient experience measures, and found that party physician groups tended to perform in line with the Massachusetts averages on those patient experience measures. Now note that these are 2016 numbers. We expect to update these measures this summer, so that will be updated for the final report. This slide I'll only spend a moment on. This was presented at the June Market Oversight and Transparency Committee meeting, showing the rate at which patients affiliated with or attributed to various physician groups received some sort of low-value care, including screenings, imaging, procedures, or preoperative care, and noting that Leahy and BILH patients tended to receive these services more often, while McKiva's patients tended to receive these services less often than average. So, as you know, this transaction is also subject to review by the DON program, and the parties have identified a set of measures that DON would monitor to assess the impact of the transaction after the transaction is finished. Some of these measures are clinical quality measures. Those measures that have been identified that are clinical quality measures are required components of the Mass Health ACO contracts, or measures that Leahy has identified for measuring Mass Health ACO performance. And as participants in the Mass Health ACO program, both BILH and Leahy would measure those, would monitor those measures even in the absence of the transaction. It is not yet clear how the parties expect the transaction would impact their performance on these measures specifically. The parties will be required to provide information about these measures to DON after the transaction is concluded, including their benchmark data, baseline performance data, benchmarks for improvement, and timelines for hitting those benchmarks.
Tasha, I'm going to just ask you to skip to slide 99 and just go through the summary here.
I will pause on 96 here to note that the parties are engaged in a variety of quality improvement initiatives at various sites across their systems, but are still working to identify which of those programs would be expanded across the BILH system. Those are plans in development. And to hit the rest of the highlights here, the parties have experience participating in alternative payment methodology contracts that incentivize both efficiency and quality performance. Their participation varies across different payer categories. Some are participating in more commercial risk contracts as opposed to more public payer risk contracting. The parties have emphasized their current quality performance and their integration planning, but ultimately, given the fact that many of the parties' plans are still in development, many key details of how quality programs will be developed post-transaction have not yet been developed in a way that would allow us to assess what specific quality impacts we expect the transaction would have. With regard to access to care, we reviewed the parties' role in serving at-risk, underserved, and government payer populations. Here you can see the payer mix of party hospitals as compared to the payer mix of patients in their PSAs. We found that the hospitals that would become BILH-owned hospitals, the corporate system, serve smaller proportions of Medicaid discharges as compared to the mix of patients in their PSAs. This slide shows the similar mix comparison for those hospitals that are current video contracting affiliates and would be anticipated to be BILH contracting affiliates, showing that these hospitals have higher Medicaid payer mix than those the mix of patients in their PSAs.
So recognizing the time, we're just going to go really quickly through the remaining things here. So as a whole, the Beth Israel Lahey Health System would be anticipated to have among the lowest Medicaid mix of any major system in Massachusetts. That's true even if you look, including the contracting affiliates, which tend to have a somewhat higher Medicaid mix, as Sasha just noted. We also built off of work that was done for this year's cost trends report, looking at income and area deprivation index. Area deprivation index is a measure of different socioeconomic deprivation factors. It's important to note that a higher number means more deprivation. Here you see that for the primary care patients of Beth Israel Lahey Health, they would tend to have among the highest average income in the areas where they live and the lowest, among the lowest area deprivation. We also cut this by inpatients, so this is looking at the hospital patients of the Beth Israel Lahey Health System. Here too, we find similar findings that in general their patients would come from more affluent and less economically deprived areas than other major systems.
Did you cut that for behavioral health?
We did not do any additional cuts. We just, for that, we're looking at just those two measures, the income and the deprivation index.
I think if you cut it for behavioral health, you'd see a higher rate of Medicaid.
Got it. The parties have noted that they don't expect their payer mix to substantially change. Obviously, given the fact that many of their plans are still under development, it's not really clear at this point to what extent they would be engaged in efforts that would specifically enhance access to underserved patient populations. But given the parties' expectation that their patient population in particular will grow as part of this transaction, it will be important for them to articulate how they expect to serve underserved populations going forward. This chart just shows a breakdown of behavioral health beds. Here we want to note that the parties serve a very important function in behavioral health. This is obviously just focusing on the inpatient side, but in outpatient services as well. About 13.8% of the inpatient behavioral health beds in Eastern Massachusetts, I apologize, these are psychiatric beds in Eastern Massachusetts will be part of the Beth Israel Lahey Health System.
Can I ask a question?
Yeah.
When the New England Baptist affiliation was approved, we were told that there was going to be more Medicaid access at New England Baptist.
That's correct.
Have you been able to determine if that occurred?
So we received the 2017 hospital discharge database relatively recently, so we weren't able to update all the analyses in the report with the 2017 data, but we did do some initial sensitivities to make sure that our findings weren't off base. One of the things that we looked at was the payer mix from New England Baptist. Here we find that their Medicaid mix in the 2017 data remains under 1%. It did go up, but it remains under 1%. So obviously we've acknowledged that many of their plans to expand services or otherwise enhance access are still under development. So it's hard for us to opine on what changes in access there might be. And that brings us to the last substantive slide. Pause here for any remaining questions. All right, hearing none. We'll go to the rest. Great. As I noted up top, we issued a preliminary report. Parties and others have an opportunity to respond to that report for the next 30 days, and then the commission will issue a final report, including any referrals or recommendations to other state agencies, and the parties may not close the transaction until 30 days after that final report.
Thank you. Now, this is an extremely important, and I know the amount of work that went into this, so I apologize for shortchanging a little, but I thought all the questions were very appropriate, and given the complexity of it, the importance of it, I didn't put that off. So, I'm now going to go through now. A number of questions were asked, and some were, hopefully all were answered. But let me give you an opportunity, each of you, to, if you want to raise other issues or make certain statements, and ask Wendy to start.
Thanks again to all of you. This was a remarkable piece of work. One comment and one question. And I think it's a comment that has been stated in several different ways by a number of commissioners, and that is that this is really the first CMIR that we have had to conduct as the parties were actually putting the new entity together. So one of the things that keeps coming up is that we have a number of questions that they are not yet able to answer. And I can remember, Kate, I think when you started out with your presentation, you were saying none of this is final and can't be final until we hear some of these responses and until the BI and Leahy and the other parties get a little farther along in their own creation. And so it's very difficult for us to evaluate this merger and acquisition in the same way we've been able to do it in the past. And so I just kind of want to put that out. I know I'm repeating what Stuart said at one point, but it does make it quite different. So that's my comment. My question is back to what now is becoming the infamous slide 67. And I wonder if we could just pop back to that. In your conversations with the BI and the Leahy folks about kind of these shifts from kind of the more expensive, and Mary Lou, let me say, academic medical centers as opposed to teaching hospitals, to the community setting, when we know that these are community appropriate discharges. This has been such a core and important point of controlling costs over time. In your discussions with them, kind of were people able to explain why this is happening or not happening? Why we are not able to shift care out of the more expensive settings into the less expensive settings? It just, and maybe that's a question that can be answered during the testimony time, but if you have data going back to 2011, that's a significant time period for data collection. That seems to me to be a really important part of this analysis, where there are data we can know and explanations we can ask for.
I will just add one point on there, in a specific example with it, which is Winchester. And so we had reported this dynamic that we actually saw Winchester being able to retain more of its local community appropriate discharges post-transaction. I think at a cost trends hearing in 2016, I think was the first time we presented that. And we did actually went afterwards and talked to the clinical leadership at Leahy, and they talked about different specific programs that they were putting in place around sharing specialists and sharing clinical guidelines with Winchester and the Leahy Burlington campus. So I think this is anecdotal, but nonetheless, we do understand that this has been a goal of these organizations, and that they have, in some cases, put in place proactive protocols and processes in order to help this be successful. Nonetheless, the end message is still a mixed one in terms of looking at the different pre and post transactions.
Okay, David?
So thank you, Mr. Chairman. I want to, this is our chance to ask questions to which we'd like answers from the parties, or that we'd like the staff to be able to provide us more information. So I want to do that. I want to do it in the context of a couple of issues that I think are important about the report and the findings. And so I want to sort of see how I see some of this and then ask the questions that follow from that. I think a first thing is, as we've done with the infamous slide 67, is understand the historical record. And my reading of the sort of entirety of the historical record here is that it's mixed. That there are some parts which are very good in that when the affiliated hospitals are owned, they really do put a lot of investment. The parties have put a lot of investment there, a lot of attempts to boost the share of people from the community that go to that hospital, boost the name recognition of that hospital. Some amount of it goes downtown, although some of that was folks who were going to more expensive downtown institutions, some of that was coming from elsewhere. It's not targeted in the sense of saying, here's a patient who's going to a very expensive downtown facility, now we're going to keep them here. It's much more sort of general. We pull in all sorts of folks from that area, both for the local and the downtown, and they're just coming from all over the place. And on net, because they're relatively inexpensive in this set of places, it saves a bit of money, but not a super amount, and it's not super targeted, nor would one expect it to be. Similarly, the prices have not gone up in those areas. So we were talking earlier, the secretary was talking earlier, and Corey Capps mentioned the finding that, the almost uniform finding that when hospitals merge, they raise prices. Here are examples of where hospitals have merged and they haven't raised prices. They have not reduced prices, but they haven't raised them in any way. So that's all to the good. So those are all to the good. And then there are some bad things, like it looks like there's more promotion of downtown. The fact about Medicaid at the Baptist is troubling. Some of the other things, it's not been as smooth as one would like. But, so that's my first sort of conclusion here, is that the historical record is generally good, but not overwhelming, and it's not entirely good. The second thing I take from this, and again, this came up earlier, but I think it's really worth emphasizing. The models here are more difficult in terms of forecasting the future. The models here are more difficult than they are in any single case we've ever had before, perhaps by a factor of 10. So we have really very good models for what happens when the dominant player in the market gets bigger by merging with a smaller competitor. And the models all essentially say the same thing. Here, the models have a very difficult time with it. And my sense of, if you attached a kind of, how certain are you of the conclusion, not in a statistical sense, but in a sort of general confidence sense, how certain are you of the conclusion? One would be less certain in this case than in other cases because there are so many unknowns. It's not quite right that the models can't handle savings, but as the secretary said, they find it a little bit harder to deal with possible savings than they do to deal with possible price effects. Which leads me to the set of questions I want to ask, in addition to, do the parties believe we're misreading the historical record? There are a couple of questions I want to ask about the savings that would help one know how to treat those savings. So I think the parties have proposed two types of savings. One is sort of back office savings, that is things that you can buy cheaper because we're both buying bed sheets and one's buying them at X and the other's buying them at 0.8X. And so therefore you can save 0.2x if you sort of choose the cheaper one, and you can do that across the board. So they're back office savings. We don't have a great sense about how big those are, or about what time frame they'll come in, or about what they would do to the need for price increases, or about what commitments that there are that those will actually happen. So I suppose the first question is, please provide us with more information about that. You explicitly noted that you didn't get a ton of that, so anything more the parties can do, I think, would be helpful on that. And then the second set of savings that the parties have spoken about are sort of savings from changes in their market position. So changes in the ability to draw patients from partners, changes in the ability to have more name recognition so that more people would go there, changes in leakage, which might be related to the ability to be able to do that. And here, I think there's really a lot that's underdeveloped or that we haven't seen that I would again like to know more about. So the question that keeps coming up, one of the questions that keeps coming up is, what could you do together that you can't do independently? So you could, insurers could already offer a narrow network that had the LAHI and the BI. And what is it that would come from being together? Well, one thing that might come from being together is we can all agree that we're going to accept very low prices. And so we can put this network together with a 25% lower price. And that's something that you couldn't necessarily agree upon because of antitrust things. Well, okay, is that going to happen? Is there, you could potentially do population health management, but these are all bigger organizations that are already doing that. So I'm at a loss for what are the things that can happen together that couldn't happen separately. If I wipe those off the table, they're only then the back office savings that I want to know about. But in general, I really want to know about both those kinds of savings because that's going to help me gauge what's happening on the savings side of the ledger in comparison to what I've got, which are estimates about what are the possibilities on the revenue or the price side of the ledger. So those are where I would like Mr. Chairman to have some more information.
I would just add one thing with your questions. I don't want to. The likelihood that these savings are going to get generated into lower prices. Hopefully, they will have the savings and help their bottom line, but making it clear. So the idea that you have efficiency doesn't necessarily mean
right. But it could affect the price increase.
I don't want to.
No. I just want to be clear on this for 1 second. Saying that, look, we need to invest in our institutions, and there are two ways to do it. We can either raise prices or we can cut costs. Far preferred for the Commonwealth is to cut costs and invest it in the institutions and say we can defer the price increases. And I count that as a victory for the Commonwealth too, assuming that spending is appropriate to take place, the investment is appropriate to take place. Does that make sense?
Going back to that, in the slide 67. So first of all, let me just pick up on something that Dr. Cutler said. So one potential possibility is what brings these parties together would and provide perhaps more efficient, more effective, and perhaps more cost-effective care is actually in the neglected part of healthcare, which is behavioral health. So when I actually look at the individual entities that are, I should probably defer this to my friend who's the behavioral health expert to my left, but I'll just take it. Is there's actually, when you look at the component parts that exist in the Beth Israel, LAHI, and some of their other contracting entities, they probably have one of the, when I say richest, I don't mean rich in the fiscal sense, but robust parts of both addictions, co-occurring, and mental illness services. And as we know, people with serious mental illnesses die 25 years younger than their non-disabled counterparts. They're extraordinarily expensive on the medical side and have extraordinarily high rates of readmissions. And if you read the Liz Quality piece from the other day, right? There's actually, if I was looking at a line of service, there's potential, but I leave that for them, for others to talk about. There's already a headline that would suggest that the merger will sharply drive up healthcare costs, and that is obviously one scenario. But to me, I guess, so the reason I go back to slide 67 is really something that Dr. Everett was also commenting on, which is the data is 2011 to 2016, if I recall correctly, and almost all of the various transactions, like LAHI purchasing Winchester, I believe it's 2014. So the question is, how long does it take for systems to start to change referral patterns, right? How do you, I mean, I don't know the answer to that. I mean, it's sort of I'm speculating like economists are speculating now. But like, how long does it take systems to change the referral patterns, to perhaps migrate people from downtown Boston to lower cost community hospitals? And like, I don't know what the answer to that is, but all of those mergers and acquisitions up there
are all 2014. I don't think any of them are pre-2014. But I was doing it quickly. You can check me and correct me on that. So in some ways, the proposed transaction also presents an opportunity, but the proponents need to convince us of this, that could create actually a system that is centered around high value and mid-price care. And moving people towards more local community-based care, because I think the component parts are there, but we need to see what are the constraints that the proponents bring to the table by strengthening the community systems and not using their market power to increase rates. I mean, I think that's the opportunity. I think that's the challenge. And as Dr. Everett says, because this is new coming together, it's going to rely on the good faith of parties coming to the table and making strong statements about the constraint of rates and the positives of bringing together these systems for the maximum good. Because the economics, I appreciate all the data, and I know I sit here and I don't poke holes, I'm just really trying to understand it from a social worker's perspective, believe it or not. And I would encourage the proponents to, we have 30 days, once we, assuming we vote to issue the report, to really come back with what are the things that would make this a very attractive, large provider, hospital, outpatient provider system in the Commonwealth that can improve quality, can constrain costs, and be an asset for the Commonwealth. I guess those are sort of my comments. And I do want to say this, I appreciate all the extraordinary work that the staff have put in putting this together for us to sort of continue to refine our own thinking on this. So thank you.
Thanks, Stuart. Well, I'll build on the Secretary's comment of thanking the staff. This is an extraordinary achievement already, and I know there's a lot of hard work ahead, but thank you so much for your care and your diligence and what you've done. It's really impressive. I want to go up a level first, as David did. It's why we're here. The aim is tripartite in my view. One is to protect the Commonwealth against excessive healthcare costs, to keep costs under control. The second is to improve care for people that badly need care. And the third subtext is to improve equity in the Commonwealth. That's actually by protecting the vulnerable people in our state. Everything I'm thinking as I look at this is the question, what will happen to costs, to the quality, and to the equity in vulnerable populations in the state. The background is not good. Our costs are far too high in the state. Healthcare is confiscating resources from other very important investments, especially in social determinants of health, way beyond that. So this is not, to me, an abstract exercise. It has to do with getting our public and private resources where they can do the most good. The problem with our commission is we can't do that. We don't do anything. We just comment. The only way to get these done is by getting help from people to give care. So we're trying to get people to give care to please pay more attention to getting the costs down, improving quality care, improving equity and justice in healthcare. One other factor that's very much on mind is that we cannot turn the clock back. There's an elephant not in this room, and that's partners. Not this combination of organizations, are strongly affecting the profile of all three of those, especially costs in the Commonwealth. If partners were to come to us before it was formed and request approval to be formed, knowing what we know today, we might well suggest not. But we're starting on a different platform now. We have a massive presence in the economy of the Commonwealth that is really determining a lot of our costs. And so, in a way, the questions I have in my mind have to do with the people that aren't here, which is what will happen to that other massive entity given one scenario, which is going ahead with this, or given the other scenario, the counterfactual of not going ahead with this. I'm going to be listening, trying to figure that out a lot. Another question on my mind is conditions that would mitigate the risks that we've heard today about costs. Is there anything that could be agreed to that would increase our confidence that the cost increases would not occur ideally, or would be moderated? We have no enforcement tools. This commission lacks only a bully pulpit and a referral to the Attorney General available to us. In general, my friends from the legal community tell me that behavioral antitrust mechanisms are not to be relied upon. Only structural ones are. We don't have any structural ones to use, not us. We only have behavioral values-oriented agreements. If I were the applicants here, I would be focusing on what the Commonwealth really needs, which is new healthcare, not the current healthcare, new designs. And to David's question as to why you might want this entity to form would be because somehow from this could emerge the kind of fully integrated, behaviorally oriented care that the Secretary is talking about that would truly be new. There's a competition between that vision of new care, which I hope will be offered, and the simple opportunity to take advantage of the price leverage here. Everyone wishes they had partners' prices, and this is a chance for these entities to go for partners' prices, and that's not going to help anybody at all. So I'm going to be thinking about what new care could emerge, and that might be worth some of the price increases that are almost inevitable here. The last point I want to make, and I'm going to summarize my questions, has to do with the vulnerable populations. I see what David sees about the mixed bag in history, but I think overall, the affiliates, Cambridge and Lawrence, have not fared well in these relationships. And I would like to see it stop. I want to see the affiliate, these key safety net affiliates do better, not worse. But you've shown us data that's famous slide here that says if you're not owned, you're not going to fare well. And we got to make sure that the vulnerable people in this Commonwealth get protected. So what's going to happen to Medicaid and Cambridge and Lawrence to me is crucial here. I'd love better predictions if we can get there. So 5 questions to take away. One is, will these entities take full advantage of the new leverage on price, or will they be restrained, self-restrained, or through some agreement restrained? Can we avoid what now looks like the inevitable price increases that the willingness to pay model suggests will be there? What would make us expect they won't take a full advantage of that? Second, we lack enforcement mechanisms, but what kinds of conditions could be attached to approval that would increase our belief in the authenticity of the intention to make better care at lower cost? Third, if there's anything we can do that would help us on, I think, some estimates of what Partners is going to do, I would value that. I know it's not in the analytics, but it's highly relevant what's going to happen to the overall cost of the Commonwealth. What will Partners do if this is approved? What will Partners do if this is not approved? Fourth is protection of Medicaid, Cambridge, Lawrence, and the contracting affiliates. How will this future be better than the past with respect to protection of the interests of vulnerable populations? And fifth, can we understand a little more what kind of truly new care could emerge as a result of this entity? Something really new on the block. Let's take the Secretary's discussion of mental health and behavioral health first, but that's not the only thing here. Better integrated care, upstream care, allocation of resources to social determinants of health, much better coordination between specialty and primary care and so on. We badly need the models of care, and I'd like to see that, see what's the potential here is. So some thoughts, thank you.
Thank you. Rick?
Yeah, thank you, Stuart. Again, I also want to thank the staff for all the great work that you've done in this. This was really groundbreaking, and it's great to be a part of it. You know, a lot of what my commissioners have said already, I would agree with. I guess just a couple of things I would emphasize. I'm looking forward to the response by the parties of the modeling of those potential price increases, because to me they don't take into account some of the other levers which we have here and in Massachusetts. Anyway, so I'm looking forward to hearing how they respond to that. I was under the impression that some of the mergers that we've approved in the past with Leahy and Winchester and Macclesfield Deaconess. And, some of those have resulted in increased volume directed to those community hospitals. And as Secretary Sutter said, I'm sure that doesn't happen overnight. And and so again, hearing more about how they would make that happen, because we know one of the reasons our healthcare costs here are high. I mean, there's a lot of reasons, but a lot of community appropriate care is delivered in the wrong place. And to the extent that we can deliver the right care in the right place, it should produce cost savings. And I guess I'll just, from my seat here as representing the business community, particularly for small employers, the current system is not working. They're really high costs, second or third highest premiums in the country. For small employers with small margins, when they get those double-digit rate increases, I mean, it just threatens their viability. And so, to the extent that this could possibly result in an attractive, lower cost, high quality alternative, it's certainly worth consideration from my perspective. So, look forward to hearing responses from the parties. This is very, well, obviously, probably the most important consolidation we can consider since our existence. So, thank you.
Marty?
I want to echo the appreciation for Kate and Megan and the work that they and their staff did on this. And I will say in the report, they put it into plain English that I think a lot of us can understand, because this isn't easy on its face. Just a couple of things I want to add to what my fellow commissioners have already said. One is I want to try to understand the long-term financial implications for these hospitals if this merger doesn't go through. We heard in Kate's presentation that there are entities here with significant losses of late. I'm particularly concerned about that because the low margins or the negative margins that behavioral health produce often make those the first thing on the chopping block. And I want to sort of assure that doesn't happen by understanding, are these organizations viable? Are they viable in their current state, regardless of the merger, and what's the viability look like post-merger? And to pick up on what Mary Lou said regarding behavioral health, these organizations are prizes in terms of what they provide in the Commonwealth in terms of behavioral health. And I think there's a great opportunity to take the work that Leahy Behavioral Health has done, particularly around the integration of inpatient, outpatient behavioral health and primary care, and really expand that to that footprint map that we saw and bring those resources and those models to other places. And would love to see the detail on that. One of the things that struck me in the report as it stands is there's a lot of, the potential is there, but the details are not. And I understand that the nature of the transaction is that we may not have those details. But I hate to ruin folks' August vacation, but the more that the proponents can come back to us with, here's what we think that would look like, building on Don's point about what is the next model here, I think that would provide a great deal of comfort to me and my fellow commissioners.
Ron, sorry, can I just make one very, very specific comment on something you're trying to say? Marty was just talking about the financial position, and I think that's worth exploring in some detail, because if you come back to what are the situations where economic studies find that mergers are valuable, they tend to be when one of the parties is in a very poor financial position that's going downhill, maybe going to fail, and then someone can come in and prop it up, and it can actually be a viable competitor. So that's the clear case, and if that's what's happening in this situation, that would be very important to understand.
Ron?
Thank you. Guys, great job. Great job in a short period of time, too. Excellent. When I look at this, I think in Massachusetts, this merger could be a plus in terms of adding competition. And I think that's really important. But as Kate, Megan, and Sasha have been going through, listening to the presentation, is that, and my fellow commissioners have also mentioned this, we really don't have an updating. As we said, if we can take the next 30 days, start filling those gaps, that is critical that we get that information. You know, the pricing, we can debate it, we can debate different models, but there are certain things that you know. And for example, when I look at the financials, and what I see is a very conservative approach to simply taking the market share you currently have and the business model and just extending that out without looking at increases in market share. And if I take what Rick had mentioned earlier in terms of employers, I'm a small employer. We're looking for options that can be cost effective, and that becomes critically important to us. Consumers are looking for cost effective options. What type of innovative programs can you come up with? And I look at the merger itself, they're gonna spend a couple of years trying to bring this together. And then, after those 2 years, where do we stand? Where are you gonna be in 5 years, in reality? And how are you going to place enough competition onto partners, for example? How much are you guys gonna place into marketing? The fact that you change your name to Beth Israel Leahy isn't gonna get Joe to stop going to Mass General. What are you guys gonna do? How are you really gonna make this a competitive environment? I think that's critical, because I think what you're doing can be positive for the state. We just need we need more information. Thank you.
Thank you very much. Elizabeth?
First of all, thank you. This must have been an incredible amount of work. I know you've devoted your summers to it, so thank you. First, I wanted to echo, I think, what many commissioners have said about slide 67, particularly in light of slide 102, that these contracting affiliates are the hospitals with the highest public payer mix. And why is that? Why are we seeing a decline in community appropriate discharges? How it's changed over time from 14 to 16. Are we seeing a similar phenomenon in Metro West, even though it is technically a contracting affiliate and yet has not actually joined in the contracts? Those are all questions I want to know more about. The last one is, I would also like to know more about the impact on the Commonwealth, particularly the GIC, which is within A&M, and it's 440,000 lives. Many of our limited network plans rely on these hospitals. They're lower cost and value, so are those in jeopardy at all if these price increases come to bear? So those are my kind of main outstanding questions. But I thank you again, and thank you to the parties. It's clear it's been a tremendous amount of work on both sides, so we look forward to the next steps.
Thank you very much. Chris?
Yes, thanks team, and the econometrics team. It was hard work. I mean, the only known, I think, is the demand is not gonna go down. First, I want to echo David Cutler's comments about needing to know more about savings that characterize this back office. I'd say really as specific as you can be in the next 30 days about opportunities for systems integration. We understand, you know, you're limited from an antitrust standpoint. We understand you're not governed as one entity, so you know, it's not like you call a meeting tomorrow morning, but you know, surely every hospital isn't going to need full laboratory services. Surely there's an opportunity to consolidate imaging. Is there a program for congestive heart failure that's going to be a product line that's going to result in better care and less cost? How about specific ideas on new population health products? I think we'd like to hear about that. There was I think a phrase in the report, I think came from you guys, on new innovative insurance products. You know, have at it. Great to see some of what you're thinking to try to understand where this could go. And I think the big question, is how is this different than 1994? You know, if the HPC wasn't here, but there is a record of what was promised. And you know, I think I'd say broadly, the quality is pretty good, but at a hell of a cost. And how's it going to be different? What's the look back going to be 5 years from now? And finally, I have a question for the commission. I don't know whether we're new at this. I don't know what the statutory limits are, but is 30 days enough time? Do we have the argument? That is statute. That's that.
It was reduced by some force of nature.
I would say with these timelines, there have been opportunities where we have come to an agreement to say to give additional time if necessary, and they can request that. But I do think we want to move this process forward expeditiously, and so getting this response, needing to analyze that response in a timely way, will enable us to complete our work on the total statutory timeline, which is the end of September.
Okay. Well, first of all, again, I want to echo my commissioners. I know how much work has gone into this. I've had many briefings, and I just get more and more impressed. So thank you, team. And I apologize for moving you forward. I would like to have spent more time. This is just complicated stuff. Let me let me focus on two key issues. One is the potential increase for price increases and spending increases. And on the one hand, I'm sympathetic to the secretaries, so well, they're one of many. I've been making predictions about the future for more years than I can count. And I think my rate is about 20% success, which is usually 10% above everybody else. So I'm pretty good. So, yeah, I'm pretty good. So, but we are dealing with a very complicated issue. I had a little, and to be fair to the staff and Corey in particular, I mean the willingness to pay model is heads and shoulders above anything that this country has ever had before. But it is still an estimate. It's still highly probabilistic, but it's the best we have. And I think it just lays out a likely where. I mean, there's just no question. But, so I think, we carry this out to 4 decimal places, but the reality is it's highly hypothetical, but it does give us a direction. So let me now switch gears. I have listened to the antitrust economists for many years, and I will tell you, I am not on their side when it comes to behavioral modification in the following sense. So if you talk to the average antitrust, like David was talking about, first of all, they tend to focus primarily on national models. So they say, how can the Federal Trade Commission or the Justice Department worry about what's going to go on in Peoria and keep track of them and stuff like that? We don't believe in behavioral modifications that ultimately don't work, which leaves you with 1 or 2 choices. Let it go forward or totally annihilate it. And what you've heard today from so many of you is there's a lot of good things in this merger. And the idea that our choice is between just letting it go forward, with all your questions notwithstanding, we're not trying to make this a win-win, I just find unacceptable. The reason why I find it unacceptable, and I'm sorry to say this because it sounds macho, but Massachusetts is different than other states. We have the capacity in this state to do more monitoring and more understanding of what's going on. No state comes close to us in our capacity to do PIP and the kind of stuff, what the Department of Public Health does, what the Attorney General does, what the Department of Insurance. So the idea that we cannot do behavioral modification in terms of doing, and many of you said the same thing, mitigate the potential. So I would say to the parties, to the extent that you can come forward with some help on reducing the likelihood of price increases, we would all be better served, because then we can focus more on the win side and less on the other side. So that's one side. I think we can deal with the price side. I think you can deal with the price. Let's move to this other issue of service mix. Now, in general, to the extent I understand a little legal, antitrust just focuses on the ability and says that it's against the law to merge, to simply raise prices. It says nothing about the impact on winners and losers. And in a kind of a cold-hearted, market-oriented, we say, the hell with the losers. If this is a better product and people want it and the losers lose, that's the market. We can't say that here because the likely losers are the unfortunate hospitals that treat a disproportionate amount of our low-income and poor populations. So we can't ignore, yes, there would be some taken away from partners, and many of you, including me, would clap and say, go for it. But we also know that there are a lot of very weak institutions that are just hanging on, and a loss of 10 or 20% of their patient load could really push them over the edge. So, again, I would beseech the parties involved here to figure out a way to minimize the losers, in fact, make the losers into winners. I think that's what you were articulating. Again, I think we can develop behavioral modifications that monitor that, so that if we were to go forward in this thing, we could really create a win-win situation. But we can't ignore these two key factors, increased spending and the potential for the losers to lose, which are disproportionate. So we need to deal with both of them. You need to deal with both of them. And as we go forward, again, I just reject the idea that we can't develop changes in this model, either because the parties agree to it, or we make it a condition, where the forces make it a condition, such that it goes forward with these conditions. Because the alternatives, I find, just unnecessarily stark. Now, anybody else want to say anything? We're now going to turn it over, since we've, yes, I'm sorry, I apologize for that. Okay, we need to vote on, again, not approving it, but as the secretary pointed out, authorizing it going forward, and the motion is up on the screen. Now, is there a motion to approve?
So moved.
Second. Second. Right. All in favor of moving forward with the report for the next page?
Aye.
Anybody opposed? Abstentions? You want to say something? You want to do this?
I don't know, it's just a roll call.
No.
Just making sure you're doing like it.
Hey, that's why you got it. All right. Move forward, and thank you again. So now we're going to turn. All right, so several of you have asked to sit down and get rid of David. So two things I'm going to call on one person to begin and then acknowledge the second person so they can be close so we can move this forward. Again, I apologize deeply. 3 minutes is not adequate, but it's in the short run, it's all the time we have. So let's start out first with Dr. Grant, our CEO of Leahy Health. And it's a pleasure to see you, Dr. Grant.
Lois? Do we have to adjourn the commission?
Wow, 3 minutes, Dr. Altman.
Sure.
I'm gonna go longer until evicted from the seat.
Bigger than I, but we've got a lot.
I understood.
Out there.
I'm the president and CEO of Leahy Health System, and I thank you for the opportunity to come in front of the Health Policy Commission today. Thank you to the staff who all just appeared upon my arrival for the extraordinary effort that you made. Two things I want to mention right out of the gate. I was taking notes as the commissioners were making their comments. Number one, the question was, are we misreading the findings on infamous slide 67? And I would offer to you that over the next 30 days, we'll have an opportunity to explain why there are multiple variables associated with those conclusions, number one. Number two, the timing associated with the evolution of the system. And number three, the extraordinary efforts that have been made by both the Beth Israel system and the Leahy system to move patients to lower costs of care. And we've got data that demonstrates that our community hospitals have grown considerably in each of our respective organizations, much more so than the rest of the Commonwealth. Second comment I want to make, and it's relative, Dr. Cutler, to your expression, with all due respect to the willingness to pay model, which I learned about today, it doesn't contemplate the Massachusetts market. And Dr. Altman, you are correct. We are different. We are different in many ways. The level of transparency, the amount of data that's available to the Health Policy Commission, to the Attorney General and others is incomparable anywhere else in the country. And it's a market where we've now got roughly 60% of our patients in accountable care type value-based reimbursement, which changes the dynamics completely. And that also doesn't exist anywhere else in the country right now. So it's not an apples to apples comparison, and I know we'll get an opportunity to discuss that at greater length. What I want to do is think big picture, not focus on the detail relative to these proposed affiliations. I came to Massachusetts 8 years ago with a charge from the Leahy board to create an integrated health system because they saw where the puck was going, and that was going to be essential going forward, to do everything we could to improve patient care and lower healthcare costs, and we've worked hard to do that. I believe then, and believe even more so today, that the cost of care in Massachusetts is way, way higher than it needs to be. When you look at the discrepancy in what people get paid for the care they deliver, it doesn't need to be that much higher than the national average. And there are things that can be done about it. But it's not going to be solved until there's legitimate competition in the Commonwealth. And I've heard it eloquently described by both the Attorney General and by commissioners sitting around this table during the 8 years that I've been here. Where's the market solution to this? And what I propose to you is that the creation of the Beth Israel Leahy system provides the market with exactly what you've been clamoring for all these years. This legitimate competition in this marketplace. Originally, Leahy was going to take care of patients only to the north of Boston, and we quickly came to the conclusion, following our affiliations with Winchester and Northeast Health System, that that wasn't adequate. We couldn't appeal to insurance companies for different types of relationships, to employers, to consumers, because we were geographically limited. Leahy Health has also repeatedly made overtures to other organizations that are represented in this room today, to communities that you talk about, to Lowell General and to Lawrence General. They made choices to go in a different direction, but Leahy as an organization has always been committed, in spite of where our organizations are located, to taking care of every patient, irrespective of where they come from, their capacity to pay. So we made the effort to expand in that direction. We've been talking with Beth Israel for a long time, and you're all aware of that. In January of 17, we announced our intent to come together as an organization. That is 18 months ago. In most communities, as you alluded to earlier, David, I think these merges happen rather quickly. So we've been working, planning extensively, and Dr. Tab will talk about it, but we've been on hold for 18 months. And there are limits as to what we've been able to discuss in terms of our coming together. Each of the organizations involved in this affiliation shares a common vision to deliver more care in the community setting. We talk about it in every single meeting that we have, our commitment to do so. They're shared values. I would say from the Leahy perspective, the affiliation is essential for both our institution and the communities that we serve. Without the benefits, which you will learn more about over the next 30 days of the affiliation that will be realized, we would have to request significant increase from the insurance companies to continue exactly the services that multiple commissioners have alluded to today. We don't make money in the behavioral health business. Dr. Everett, you're going to keep me on schedule. Okay, I'll be concise. What we have in Massachusetts today is not sustainable, and it's going to deteriorate quickly. I'm going to repeat that. What we have in Massachusetts today is not sustainable and it will deteriorate quickly. More care will be delivered in higher cost settings, and you've seen those trends. That's going to continue at an accelerated rate. We won't be able to make the investments that are necessary in population health and doing it the right way. And frankly, most in Massachusetts dabble in it compared to the more mature integrated systems across the country. The Intermountains and the Geisingers of the world take a much larger chunk of their resources to invest. That's going to need to be part of a larger system. We can't compete with the state's dominant provider, and we run into it every single day. I'm going to read the bold print for you, Stuart. The gap between the haves and have-nots continue to grow daily. The 2-2-4 pricing strategy, where everybody's getting the same increase every year, means that the dominant provider gets more built on its base, and therefore the gap grows on a regular basis. I noted the 3% increase to the Health Policy Commission budget for next year. I've not seen 3% in the 8 years that I've been in Massachusetts, while our costs have continued to escalate. So in spite of your efforts, significant efforts to control costs, they've continued to increase, and it's going to get a whole lot worse. Without a transformative change in the market, all of the fundamental problems will worsen, and you know what those fundamental problems are. Your reports have repeatedly come to the same conclusion over 8 years, and I haven't seen a substantive change in the entire time I've been in Massachusetts. I'm going to be leaving Massachusetts in the near future. We're moving back to family. You know that. This may be my last visit to the Health Policy Commission.
That's why I'm giving you extra time.
Massachusetts desperately needs a market solution before it's too late, because every other organization in Massachusetts will be further debilitated over time. And even with changes down the road, their ability to be effective competitors is going to be limited. And that's what I'm seeing happening across the board with multiple other organizations. What's the option? I haven't seen a rational option proposed in the time that I've been here. Is there a viable option to change the dynamics in the market? I believe that what's being proposed by these organizations coming together represents the best opportunity to create a competitive marketplace. Thank you for the opportunity to speak.
It's going to be hard to function without you around. I mean, you've been a tremendous positive force, and I'm sorry to see you go.
I'll bring my grandchildren back for the next meeting.
Dr. Taub, it'd be good to hear from you, the CEO of the Beth Israel Deaconess Medical Center and the medical system at BILH.
Great, thank you, Commissioner, and all the commissioners and staff. I really, really appreciate it, and we appreciate your inviting us here to talk a little bit more about our vision. I know that time's short, and honestly, Dr. Grant, I don't know how to follow something like that. I think he stated it incredibly well, but let me just turn a little bit from the past and the current market to a little bit about the vision and a little bit more about our commitment. I want to be clear. We absolutely share your commitment to strengthening patient care and reducing healthcare costs, and to expanding access to all patients. You've been at this for a long time. We've been at this for a long time. Dr. Grant said it, and some of you said it in different ways. It is time to try something new in this market. And we think we can do that. We understand. I listened very closely to some of the issues and concerns that you raised. And I don't want to dismiss those. I think that there are legitimate issues and concerns that every single one of you raised, and far be it from me to sit here and glibly dismiss them. I also think, though, that they can be addressed. Our vision is really to transform the region's healthcare in ways similar to what Dr. Berwick is asking for. And I think we have the ability to be more concrete about it than we have been. And my commitment to you, even in the coming 30 days, and I'm very appreciative that everybody's concerned about my summer vacation, but we have the ability to be more specific, and I'm committing to you that we will be more specific in the coming days. What exactly are we talking about? When we're talking about a new system, what would that mean for patients and families and communities? We believe that by coming together, there are a host of things that we simply can't do on our own, and I'm committing to be more specific about those things, even in the coming days. You know, over the last 18 months that Dr. Grant described, after signing the definitive agreement, one of the first steps that we took was we created an integration planning process. We took more than 250 stakeholders across the entire, what would be combined enterprise, more than half of them clinicians, over 35 different design teams, and we developed very specific, very concrete plans for how we would achieve what we're saying we want to achieve, and how we will hold ourselves accountable as a system. I've got a long list of examples, and I don't have time to give them today. I'm going to give you one. Behavioral health. So we believe we need to build off of the experience of Leahy, EID Plymouth, and others to create a system-wide approach to collaborative care that simply doesn't exist in the existing systems. Embedding mental health and substance use providers in over 100 of our primary care practices, which would extend access to over 500,000 patients who can't conveniently access those services right now. We have concrete plans for doing that, for making the investments we need to do. That is one of over 150 different specific recommendations that we are thinking about and working on, very much hoping will be very different than the way that healthcare is delivered today. I think it's more than a hope, that we are being specific about it. I'd say we really look forward to sitting down with the commission to share those plans. I'm confident that we can do it because on a smaller scale, we've done it already. The community hospitals that are integrally part of the Beth Israel Deaconess and the Leahy system, they've been able to attract new patients. They've been able to add new primary care physicians. They've been able to bring more specialized services to the community. Those community hospitals have grown and grown pretty well, and they've improved their financial performance, and they've expanded their services so that we can meet the needs of the communities in the communities. We think we have a track record of doing it. Just want to take one more moment and talk a little bit about who we are. Because, first of all, Beth Israel Deaconess Medical Center, founded off of institutions more than 100 years ago, that were founded to meet the needs of the underserved. And we're really, really proud of that, and our commitment to doing that does not change. We want to, as I said, build off of Leahy Health's leadership and expertise, particularly in behavioral health. There's been a lot of discussion about Medicaid, for instance. Marty Cohen raised the issue of what is the payer mix, for instance, of the behavioral health components that are being provided within the system. Well, I'll tell you. Leahy Health Behavioral Services has a payer mix of 67% Mass Health. It's the largest provider of outpatient services in the Mass Health program. It's got more than 1 million patient encounters across 45 different communities, well beyond the primary service area of Leahy Clinic. It's one of the only truly comprehensive array of behavioral health programs that's out there. By the way, it's also the primary emergency services provider for behavioral health patients in communities like Lawrence and Lowell and Salem and Haverhill, not just in Burlington. At BIDMC, we're pretty proud of our long-standing relationships with many community health centers, whether that's Bowden Street in Dorchester, or Dimmock in Roxbury, South Cove in Chinatown, Quincy, Malden, Charles River, Fenway Health serving the LGBTQ community, Outer Cape. These community health centers, some of which are integrally part of us, some of whom are tightly affiliated, they serve more than 120,000 patients a year. More than 50% of them are either on Medicaid or uninsured.
Dr. Tab, you need to cut it a little.
Got it. I guess I'd finish in the following way. I think that thanks to what is really a very different environment in Massachusetts, an extraordinary level of cooperation and collaboration among all the stakeholders, the Commonwealth has made good efforts in lowering healthcare costs, or at least lowering the rate of increase. And I think the Health Policy Commission deserves a lot of credit for the progress that's been made. And yet the costs continue to increase. And much of that cost growth is driven by the fact that patients are receiving care in the most expensive settings. And you alluded to that. We need to work on that. I want to say, I absolutely hear and I recognize the concerns that are raised by the commissioners. You should know that we are committed to sitting down and working together to address them. We can, as the chair pointed out, make this a win-win situation. We need to. And we're prepared to be accountable. We're fully anticipate a monitoring system that ensures that we not just say we're gonna do what we do, but actually follows and makes sure that we do what we do. And I'm looking forward, I'm not exiting to Philly to be with grandchildren. So I'm looking forward to many more years of sitting here with you and reviewing that progress. So thank you again for the opportunity to be with you here and your continued review and consideration.
Thank you very much. All right. All right, we're now gonna answer Dr. DeShane, William DeShane, who is CEO of WellForce.
Thank you. Well, unless I got a medical degree coming across the floor, I'm not a physician, so I want to clarify that.
But that's all right, some of us aren't either.
That's fine. I'm Norman Shane. I'm the CEO of WellForce, which is the parent system to Tufts Medical Center, Circle Health, Global General Hospital, and Melrose Wakefield Healthcare. At WellForce, our mission is really pretty simple. It's to provide value, high quality care to all the communities that we serve. And we take pride in what we've been able to develop, and we've been recognized by this group and others over the course of the 4 years we've been together. And we have moved care to the community. We've been successful in that, and then we take great pride in that. First, I'd like to thank the staff and the commission for your rigorous analysis of this proposed mega merger. This proposal really would create a partner system overnight. And I think I heard Dr. Berwick say that, you know, if we had it to do over again, we probably wouldn't. But this group wasn't around then. And I think that's one of the basic questions we have to ask ourselves. Is this something we want to do, and is it the right antidote to probably a course of action that took place many years ago that none of us really had any input on, but it affects the landscape of healthcare today in Massachusetts, and clearly this is of concern to all of us. The creation of partners had really negative cost consequences across the state, and I don't think we can allow that to happen again. The scrutiny you're providing didn't happen in the past, and now it's critically important that we do so currently. I welcome the opportunity to share a few other concerns with you. But prior to my role as the CEO of WellForce, I was the CEO of Global General Hospital for 14 years. I've been in the state for over 40 years. During that time, I have a good firsthand knowledge of a lot of the dynamics within the state healthcare system, as well as it's with that firsthand knowledge that I'm here today to talk to you about challenges for communities like Lowell and Lawrence and others. And I have serious concerns because of that. First of all, I think the merger is too big, too fast. Put together a big bang of bringing together this many hospitals at one time. It's difficult enough to look at 2 hospitals coming together, 2 systems coming together. Trying to analyze 13, I think, really speaks to the complicated discussion that staff had before them. The tremendous work that they did do still came up, I think, had with many more questions than answers for the commission. This will create, in my opinion, a duopoly. As you've shown today, a merger of BILH would cannibalize commercial volume from others. I think the number I saw up there was nearly 15% from WellForce. Lost in the analysis was the fact that we were compared in terms of what the impact would be in terms of cost, and that it had a negative cost impact. And I think part of that is because we were merged in there with what the impact would be, would take it 50% or 56% away from partners. So I think the negative impact on a lower cost system like WellForce would be a lot more significant and would actually represent a significant increase in cost. These systems already care for a higher percentage of Medicaid as well and provide very badly needed community service that's not just about mental health, but is about adult care, pediatric care, and obstetrical care in communities. And I don't think we can continue to risk to further destabilize those community hospitals and those providers in those communities that where a lot of care is provided. Next, I think this transaction will exacerbate and not really abate the disparities that exist today. We're baking in and continue to bake in cost discrepancies between a lot of tiers. And so, although we may be a bit giddy about trying to close the gap between partners and another system, what we didn't talk about today was the gap between that new system and other providers in the state, and how the ability for those providers to compete and to recruit staff and recruit talent and physicians and provide their mission to serve those communities is going to get lost. But also, I think, despite what we've heard today, we'll see costs rise as a result of this transaction, as Leahy and BI need to bulk up to be able to actively compete against partners. The impact to communities and citizens across the Commonwealth will be real. I think it's going to increase the burden on our lower income communities, and they'll have to further subsidize the cost of care. And I wonder who's going to subsidize the cost of care if hospitals in Lowell, Lawrence, Brockton, and others start to get really destabilized. Who's going to care for those populations and who's going to pay for it? Lower cost providers will struggle and to continue to sustain and invest in their services. And in my opinion, this really adds insult to injury. The work you've done here today is really remarkable. My compliments to everyone. I think it makes it clear, though, that we have to ensure, and I agree with Chairman Alman, that this is Massachusetts and we can do better. We can find some solutions. But we have to make sure those solutions don't have a negative consequence on the underserved population across the state. And some of the communities that haven't been named in this merger or in the partners merger. Going forward, I think we owe it as a public policy stand to take a stand. That's why I'm here today, because as from a public policy issue, I'm very concerned about some of the communities that are not represented in these mega mergers going forward, and what the impact will be on the populations that we serve.
Thank you.
Thank you.
Okay. All right, Mark Durrod, who is the president of Stewart.
I'm not well.
Thank you for having me. Let me give you a little bit of background. I am a physician. I spent the first 17 years in practice as part of the Partners Healthcare up at then Salem Hospital and now North Shore Medical Center. Then in 2009, somehow I was dragged out of that practice to join Ralph and start the journey that is now Stewart Healthcare. I was the guy responsible for building Stewart's accountable care organization and its model. Worked with some of you on that initiative. I then began to worry about the role of hospitals in value-based care. So I had the opportunity to actually run our 11 hospitals for two and a half years. And now I'm back on the network side trying to put those two pieces together in a more effective, innovative healthcare delivery system. So I thought what I'd do is make 3 quick comments, and as a physician, I'm going to try to stick to the 3 minutes. One on quality, one on access, and one on cost. And I'll do that in reverse order. On the cost side, I think the arguments presented today are pretty clear that there's going to be a temptation to raise rate and therefore result in increases in total medical expense. That combined with arguably the largest healthcare system in the Commonwealth will certainly translate into potentially higher premiums. I just want to make the point that the people and the employers in the underserved communities are the communities least capable of tolerating that. So I agree that Massachusetts desperately needs a solution, but not at the expense of our vulnerable populations and not at the expense of our community, low-income people and the providers that serve those, whether it's doctors, social workers, community partners, or hospitals. On the reduced access side, again, the combined entity will have about 13% Medicaid payer mix, state average at 21%. The underserved communities that certainly Stewart serves are much, much higher than that. By increasing rate, and the market dynamics will be such that the merged entity with increases in rate and the ability to reduce the cost of goods sold is simply going to increase their profit margins. And disparate communities, by giving up volume and having limited resources, their margins are only going to decrease. Somebody made, I think it was Kate, made the comment that it does look like in these merged entities that physician rates tend to be uniform. And guess what? They tend to be higher. In that case, you're going to drain both physician resources in these communities, and you're going to reduce already razor-thin margins in community-based hospitals. That is going to result in service line gaps. And you're going to see the lost leaders, behavioral health, for instance, one of them, begin to move out of community-based settings, which doesn't help anyone, particularly these populations who have a bunch of social determinants that limit access to care. So finally, on the quality and care delivery front, I think it's pretty clear that the underserved communities are having a tough time building the infrastructure around population health and managing population health. And there is one impact that hasn't been considered today that I think you need to be cognizant of. To the extent, for instance, Steward is usually into accountable care and has all kinds of global capitation contracts across the entire payer spectrum. Rate increases at an organization like this has a profound negative impact on our ability to manage our budgets because it's against our global capitated contracts. So to the extent that I don't have the market power to negotiate that, remember the economist who mentioned it, it's not just a negotiated impact. To the extent that more than half the care in these communities leaves the communities and goes to higher cost centers, that has a huge impact on the ability to perform under these alternative payment models. So,
You're way over.
okay, what I would say in closing is, look, as healthcare providers, we have two obligations to the communities and people we serve. One is to promote wellness and prevention and to manage chronic diseases for those that have chronic diseases. And two, when that fails, is to provide world-class health care when those patients ultimately get sick. This merger potentially could negatively impact that opportunity to achieve that for the most vulnerable populations in Massachusetts. So I just want to make sure that we remember that in the analytics.
Thank you very much. I really appreciate that. Okay, Nelson, representing South Cove. Again, I need to remind everyone, we need to stay within the 3 minutes as much as possible.
I'll read, that'll be efficient.
Thank you.
Mr. Chair, members of the commission, thank you for the opportunity to appear before the commission to speak on behalf of the proposed merger that's before you. My name again is Nelson Liu. I'm the current board president of the South Cove Community Health Center. I've been a board member for 6 years. South Cove serves 33,000 patients in the Commonwealth from over 120 different zip codes. We're currently entertaining 180 visits a year between 5 locations, one of which we just opened in Malden. For 20 years now, the partnership between South Cove and BI has been forged on a relationship that has been mutually beneficial to both parties. But most importantly, it has been beneficial to our patients who, for our mission, has been for 45 years to provide healthcare that is culturally and linguistically appropriate. Our communities tend to be Asian, and with the partnership with BI, we've been able to work together to provide special services as well as just general services in an efficient and profitable manner for our organization as well. With BIDMC, we're part of the Midco ACO, which South Cove continues to work at serving the underserved in our communities by providing care to some 13,000 patients who are covered by Mass Health. I've stated in previous testimony, our board is in full support of the merger. We believe that healthcare can be provided with high quality, with efficiency, with high standards, because we can work together, not as individuals. And so that's why we support this merger. So thank you for the opportunity.
Appreciate that very much. Hanoi Reyes. The next person is going to be Elizabeth Brown. So if you can get close to the mic.
Good afternoon. My name is Hanoi Reyes and I am a resident of Jamaica Plain. I'm also the spokeswoman for the Make Healthcare Affordable Coalition. I want to start off by thanking the HPC commissioners and also the staff for looking and scrutinizing this mega merger. I am here representing diverse community leaders and advocates from across Eastern Massachusetts who have grave concerns about the 13 hospital mega mergers led by Beth Israel and Leahy Health. Many of our members are here today, and I want to thank you for hearing and listening to their concerns. So the track record shows both BI and Leahy Health that the merger, that they do not serve communities of color and communities of the working class. Oh, sorry, thank you. I hope you hear me better now. So if we look at their other findings with the state, they will focus on patients that have a household income of $112,000 a year. I am grassroots in the communities that I represent do not meet this income brackets. By joining together Beth Israel and Leahy will form a second Goliath in the market with partners, resulting in a dual police system for Massachusetts. So once we have this dual police system, there will be no going back. Is this the legacy we want to leave in the system? We understand that there needs to be a solution, but not at the cost of the low-income and working class people. That is not the foundation where the hospital, community hospital for model that Massachusetts was founded on. Today's report shows that the merger will increase costs by $250 million per year and leave communities of color behind in order to generate bigger profits. Over the past year, we have held community conversations from across Eastern Massachusetts, from Lawrence to Lower to Methuen in different communities. So they are scared of the financial impact that this merger will losing their doctors as well. So we are worried that Mass Health patients will be turned away. I have heard from people who say they do not have the transportation money to pay $60 each way to get for a cab ride to get to the nearest Beth Israel or Leahy Health Center. for a procedure. So again, I thank the SBC for bringing this merger process out of the darkness and into the light. I urge you to take the next step and refer your findings to the Attorney General Mara Healy to fully investigate the impacts of this merger before it is too late. We also call on the Department of Public Health to review their previous findings and take action to protect communities of color in the working class community by stopping this merger indefinitely. Thank you.
Thank you very much. Elizabeth Brown?
Good afternoon. My name is Elizabeth Brown. I'm the Executive Director at Charles River Community Health. We're a federally qualified community health center with locations in Austin, Brighton, and Waltham, and have been an affiliate of the Israel Deaconess Medical Center and Mount Auburn Hospital since 1999. Our patients are largely Mass Health and uninsured. We have the unique privilege of actually having some of the highest uninsured in the state. So we're a very large immigrant community, and have a very culturally diverse patient base as well as staff base. So the majority of both our staff and patients are from communities of color. I respectfully understand the concerns of folks who have spoken here today, and I think some really good questions have been raised. But what I would like to state is that Charles River Community Health, in fact, decided to affiliate with both the ID and Mount Auburn specifically because other hospitals at the time were not willing to work with us to serve our community. And we've experienced nothing but 100% commitment by both of those hospitals to serve both our insured and uninsured patients, as well as our patients on Mass Health and who have interpretation, transportation, and other barriers to care. So we are in support of the merger. For our providers, it actually would help in terms of bringing the systems of care together. And I think you definitely are asking some good questions around coordination and efficiency. I think those things need to happen. But from our perspective and our providers' perspective, we're in support of this. And I will just say, these hospitals state their commitment to serving those communities, but our experience is that they walk their talk. And so as a result of that, we support the merger.
Thank you very much. All right. Bonnie Gilbert?
Good afternoon, Chairperson Hawker and Commission members. My name is Bonnie Gilbert. I'm a member, strategy team member of the Greater Boston Interfaith Organization, GBIO, and I'm chair of the GBIO Healthcare Team. Thank you for giving us this opportunity to comment on the preliminary report. As always, we deeply appreciate the hard work done by this commission to provide us with independent, deeply researched data and information. We actually value the work so much that we've been withholding a final position on the merger until receiving the analysis and preliminary report today. Based on what we've heard today, what appears to be a potential increased spending of $200 million a year, we are clarifying our position to unequivocally opposing this merger as it currently stands. Additionally, we urge this commission to do the following: to go beyond offering a written public comments period and hold a public hearing prior to the completion of your final report, and we request that the hearing be held in the evening. The potential consequences of this merger are too dramatic for any final report or the decision makers acting on the final report to move forward without an opportunity for a variety of informed stakeholders, especially the citizens of Massachusetts, to weigh in. 2, the information that has come forward today, namely the concerns that you have noted about potential cost increases to the Commonwealth and to premium payers, only fortifies our position that no merger should be allowed to go forward without containing a condition that would mandate the unwinding of this merger if, after 2 years of operations, it is unable to demonstrate that it is resulting in a decrease of cost to consumers, patients, and businesses. As we've seen today, savings to the providers does not necessarily result in lower costs and prices to the patient. Accordingly, if today's findings are sustained in your final report, we urge you to refer this transaction to the Attorney General and to the Department of Public Health for the purpose of their either stopping this merger or to put this needed condition in place, as well as additional conditions to prevent the harms that you have identified. We also agree that Massachusetts is a special place, but the laws of economics apply here as well. So GBIO continues to state that we support the stated goals of the merging parties, and we would like to accept these goals on their face as well-intentioned. But we repeat, as we have stated in the past, the citizens of Massachusetts cannot afford for them to fall short on these promises, especially in light of today's stunning numbers. Promises made cannot go unmet. If this is to move forward, it must contain additional conditions, and these conditions must be explicit, they must be enforceable, and they must carry extraordinary consequences for their failure. Thank you very much.
Thank you, and I also want to thank GBIO for all the efforts that you've put in over the years with us.
Thank you very
Appreciate
much.
it very
We
much.
appreciate it.
Thank you. All right, Philomena Baptiste.
Good afternoon. My name is Philomena Laptis, and I am the Executive Director for Bowdoin Street Health Center. My relationship with Bowdoin Street Health Center goes back almost 11 years when I had a personal emergency with my daughter. Having lived in the community, been a lifelong resident, have known about the health center, my first time actually walking into the doors was the day of that emergency with my daughter. And since then, different opportunities presented, and clearly I'm now the executive director, but I've been there for over 10 years. Our relationship with the hospital dates back in the early 90s, where we were dissolving our relationship with Kearney Hospital, and we surveyed our patients to find out what would be the hospital of choice. And their number one choice was Beth Israel Deaconess Medical Center. And with that, we've established, we are a hospital licensed community health center and have had a great relationship this far. We have partnered with them on things around violence intervention and prevention, our trauma services that we provide to the residents in Bowdoin, Geneva, also our work around food access. The medical center has played an integral part in all of the services that we provide, including a lot of things that we're trying to do around wellness and integration. In fact, the hospital was the first to commit to our campaign around wellness so that we can expand our services not only to do work around prevention, but also work around intervention for our very most high-risk patients. So with that in mind, I asked you to please consider, there was a lot of conversation today about the underserved and equity or the inequities that exist, and I can attest to the hospital's commitment to our community and to the patients we serve. We serve over 11,000 patients, and most of which are African American, Caribbean Islanders, Cape Verdean, and most of which also are Mass Health patients. So I thank you for taking all of this into consideration, and I just want you to know that we are in support of the merger. Thank you.
Very much. Yvette Gonzalez.
Good afternoon. My name is Yvette Gonzalez, President of Vanilejos Unidos en el Exterior. Our organization represents Dominicans and other communities of color across the Boston area. I'm testifying today because many of our members rely on community hospitals like Kearney Hospital in Dorchester and Taft Medical Center in Boston. They are worried that this mega merger led by Beth Israel and Lady Health will create a new system that they can't afford or access. We are also worried that community hospitals like Kearney and Taft won't be able to compete with the merger. This will leave low income and communities of color behind. because the mega merger won't serve mass health patients, which is the only type of insurance a high rate of our communities can afford. The merger also won't have the type of culturally competent care that our communities need. I respectfully ask the HPC, Attorney General, and DPH that the mega merger be rejected. Instead, we should work together to support community hospitals and health centers which provide high-quality health care and affordable costs for all of Massachusetts residents. Thank you.
Thank you very much. Shorty, Smarty.
Good afternoon. Thank you, HPC, for giving me the opportunity to come here. My name is Chobi Wansosati. I'm a mother, a resident of Lowell, and also a human services worker. So I have been hearing about this merger for like about 6 or 7 months, but as a resident of Lowell, I can say that it is not known at all at the local level. So I come forward today, and again, actually I forget to thank you about the extraordinary report. It's very impressive, and I learned a lot today, and it even helped to clarify my position in regard of the merger. So I come forward today to express some concern as a community local resident. So in Lowell, as you might know, is the second largest city in the United States with Cambodian population. So Lowell General Hospital and Lowell Community Health Center at the center of the healthcare for those people. And I can tell because I go there and I also work with people who goes to receive care there. They have specified cultural and linguistic sensitive care that are provided to our population. So the concern are first, if the merger would go through, it would suppress the specified services that community center and the local hospital would provide to local population, like community like Lowell, for example. So the second would be that good doctors will be stolen from us, and then healthcare will be rerouted to elsewhere than Lowell. And as I said, as community human services worker, I can tell that transportation is already a huge challenge for our community members. So, as a matter of fact, I would like to strongly urge the rejection of the merger. And thank you again for the opportunity to speak.
Thank you very much.
Thank you.
Okay. All right, that completes the number of individuals who have signed up.
Sorry, Stuart, we have one more person.
Oh, we do.
Cindy Donaldson from Edison Gilbert.
Okay.
Hi, thank you for this opportunity to comment. My name is Cynthia Capasso Donaldson, and I'm Vice President for Addison Gilbert Hospital as well as Leahy Outpatient Center, Danvers. I'm a lifelong resident of Gloucester, and I'm speaking in support of this merger. Addison Gilbert Hospital serves a diverse population of primarily underserved individuals with complex medical needs on Cape Ann, which is a geographically isolated area. Before joining Leahy Health, we were struggling to maintain our operations. Our affiliation with Leahy Health has enabled us to grow our patient volume, invest in the services and resources that our community needs. For example, the Gloucester community has been hard hit by the opioid crisis. Our ability to care for patients suffering from substance use disorder has been greatly enhanced by our relationship with Leahy Health Behavioral Services. Addison Gilbert could not have done this alone. Simply put, our hospital would close were it not for the affiliation with Leahy Health. Instead, we are still here, we are growing, and we are investing in providing quality care to people in need throughout Cape Ann. Thank you for your consideration.
Appreciate that very much. Okay, we okay now? All right, any further comments or questions from the commissioners? If not, I will accept the motion to adjourn.
Move to adjourn.
Second, all right.
Thank you.